papers relating to the public and patient engagement, whether it's patients related, whether it's papers relating to real challenges around quality, or in fact the whole context of how we work. Many of you will be aware of the work of the Bevan Commission and its thinking around prudent health and care and the principles implicit within that. This is now used as underpinning policy alongside value-based care to ensure that we have and continue to address the key issues set out, if you like, by Anna and Bevan over 70 years ago. But we are very keen to make sure that whatever we do, it is fit for the future. There's no point in hanging on to things from the past when we have to make sure that whatever we do, we are not only fit for now, but we are fit for the future. And many of us will have experienced changes through the last 18 months. We are about trying also to ensure that our thinking and our analysis and our interpretation, the collective, if you like, wisdom of our commissioners is translated into policy. And our Bevan Exemplars was just part of a way in which we could help translate those 4 principles into something that was meaningful in practice. As we all know, change can be difficult, challenge can be difficult, and we've certainly learned an awful lot in the last 18 months. But the real issue for us was, how do you change? How do we help people change when it's very easy and very comfortable to retain what we're doing, to keep doing the same thing and to keep working in the same way? There are some people who enjoy change and challenge. There are others who are less open and feel generally uncomfortable with it. We started off a number of years ago by inviting people in the system to come up with their ideas of how they thought we could translate those core principles into practice. And we invited people from across the whole, initially the NHS, but more recently from the care sector as well. And people stepped forward. They didn't know what they were putting their hands up for. They stepped forward with some ideas, and what we did was support them through a journey, through 12 months of, that's all they had, 12 months of exploring something different, exploring an idea they may have had, exploring a thought that they thought that something could be done better. We had no direct resource to give them. We brought around them a whole range of support that we felt would help them and that they felt would help. So the idea of the exemplars grew over time. And I think it's really important to say that over the last 5 years, we have seen a considerable influx of examples and innovations and creativity from allied health professionals. And it was this that really spurred on a conversation with Ruth, which said, actually, we need to be really sharing this further. We need to be doing something more with this than just presenting them and then perhaps walking away. We are really keen to continue following this event, to work with the Allied Health Professional Committee to ensure that these ideas don't just remain, if you like, online. They don't just remain in different parts of Wales, but they become a fundamental part of a new way of working. We are really excited about where this is going to go, and we're really keen that you attending today are part of that journey with us. We all know that actually the ideas alone are not the thing. We have to ensure that we take these ideas and make them work in practice. For those of you, we will be seeing some of them, sample of these today. We're really excited. We've got them, the individuals involved here today, just to highlight what they found, their journey, and the new, if you like, ways of working that they identified. For those of you who are interested, there are further examples on the website. But today really is about sharing and communicating what we've seen and what these individuals have shared and developed over time. They're about conversations between yourselves and others. They're about also a bit of self-challenge and change, because we are all, as I say, we all get very comfortable in our own little ways. This is about an opportunity for you to reflect on the way you work, the way your team works, and how you might take advantage of these opportunities. Ultimately, it is about how we can take the ideas that have been tried and tested and proven to be successful and make sure that they are adopted and spread across Wales. And I'll be coming back to that a little later. But I'd like to, we've got much more detail for you on the programme in a short while. But before that, I'd like to just hand over to Ruth Crowder, who is chair of the Allied Health Committee. Thank you, Ruth.
Thanks very much, Helen. So I'm really pleased to be here today and really looking forward to the day. And I want to thank all of you for creating the space to join us in what I know are phenomenally challenging times. I'm the Chief Allied Health Professions Advisor in Welsh Government. I've been in post just over 3 years, and probably the most interesting 3 years we could have found. So it's been an absolute pleasure to work with all of you, but specifically with the Welsh Allied Health Professions Committee. The committee is there to provide that expert opinion and draw together all of the professions in all the AHP professional advice and opinion to help myself advise government and to help Welsh ministers make decisions about the way forward for our services and ensure that that AHP voice is heard. The impact of the last 18 months has been beyond what any of us have experienced. And I think we can realistically anticipate that the next few months are going to be no less tough. And that, I think, really underpins what Helen has just said, that we really all have a responsibility to ensure that what we do is as effective and impactful as possible. And hopefully all of us now recognise, even those of us that don't like change, that we do need to transform to meet the needs of our population. We cannot go back after this real break in the way we've delivered services. I think all of us have come into these professions to deliver the highest quality of outcome and experience to the people and communities we work with. And that needs to be based on applicable, robust evidence, underpinned by the highest quality of clinical reasoning and shared decision making, based on an appreciation of those unique needs of every single person you work for. So an event like today allows us to learn, share and open our minds to the art of the possible. And the presentations today show not only what and how we can do things more effectively, but also help us to understand how they've achieved that change, how we articulate our contribution, the evidence of its outcomes and the benefits for all of us, so that we can build on our existing knowledge and experience, but secure our employers and organisations' understanding of how to use our skills to maximum impact and value. When I started 3 years ago, we began a piece of work to develop the first national AHP framework for Wales. Programme team are now in place and will be starting the work towards the vision that we all co-created over 2 years ago. The framework remains closely aligned to our new programme for government and the priorities of our new minister to deliver the best possible outcomes for our citizens as close to home as possible. To improve access to our services and skills and to respond rapidly and effectively to prevent greater need in the longer term. Work is going to have to focus on how we improve access and how we deliver effective care in primary and community services. We need to focus on how we can enable people to have their care as close to home as possible. We're going to have to support those people who will be waiting for treatment to ensure they keep as well and fit and motivated as possible in order to be ready to benefit from their essential treatment once that becomes available. Those of you in hospital services, including those of you working in emergency departments, will be focused on maximising recovery and providing the treatment and rehabilitation to return people home urgently as soon as their acute treatment is complete. We have to ensure that people are only in a hospital bed when they have a real clinical need to be in that bed. The AHP framework is based on the quadruple aim underpinning the Healthier Wales long-term plan. So the quadruple aim, it says on the can, has 4 aims. It's about improving those population outcomes, It is about enhancing the quality and access to allied health professions. It is about inspiring a vibrant workforce, and therefore, fourthly, securing the highest value from allied health professionals through transformation. And that's why I think today is such an important contribution to the work that we are all going to be looking to achieve over the next year and on into the future. I know today is a real celebration of the work that you're doing to achieve those 4 aims. I know many of you won't be able to stay all day, but whichever sessions you attend, you can use what you learn to secure those 4 aims. I hope you will enjoy the day. And I want to thank you all for the phenomenal work you're all delivering to improve the care of our most vulnerable people. And I'm really pleased to hand back to Helen. Diolch yn fawr.
Thank you very much, Ruth. And just to reiterate, this is really brave and bold individuals who have stepped forward here today. They've worked hard over and above their day job to develop some really interesting and innovative ways of working. This will be the way of working for the future, whether it's looking at how we can adapt the way we work, whether it's about making services closer to home, as Ruth has said, and whether it's just how we can maximise that use of technology without losing that personal context and contact with our patients and with the public. We hope that today and the agenda that we've got today will inspire you further. This isn't just about a point in time. This is about a journey, a process. And we really look forward to continue to working with you all and the committee to make sure that we build on this excellent start that we've seen today. So without further ado, I'm just going to hand over. We've got a short video really, which sets out the details of the day so that you can see what we've got ahead. And above all, please enjoy the day and please come back to the last session where we will be also looking at the next steps. Thank you very much, everyone.
Good morning. My name is Lisa Love Gould and I am lucky enough to be chairing session 1. I'm the Clinical Director of Allied Health Professionals in Cwmtach Morgannwg University Health Board, as well as being the chair of the Welsh AHP committee. So really delighted to be here with you this morning. So thank you all for attending. I think it's been really clear in that video that I'm not allowed to munch away during this. I'm a bit upset about that. But feel free, relax and enjoy the session. If you can ask any questions through the question and answer box on the side, the team will pick those up. So hopefully we'll have an opportunity to ask questions afterwards. So I'm hoping that you're expecting to hear all about the occupational therapy intervention for recovery through activity. It's an online intervention. So I think that video is about to play.
Hello everyone, I just want to introduce our project called Recovery Through Activity, Implementation and Evaluation of an Online Occupational Therapy Intervention across Wales. Recovery Through Activity is a 12-week course designed to help people experiencing mental health issues to explore the different categories of activity as part of their recovery journey. So Recovery Through Activity itself is usually developed face-to-face, or delivered face-to-face rather, and was being delivered across a number of health boards across Wales. But back in March last year, the OT leads across Wales met, and with the advent of COVID, we decided to look at moving this intervention online to create a choice of approaches when delivering recovery through activity. We were fortunate to have an OT lead in clinical practice and education from an Iron Bevan, who carried out an analysis of all the outcome measures, which led us to using the role checklist version 3, looking at people's roles and identity and confidence in engaging in activities. We also wanted to use that as a post-course checklist as well for people to complete. We also use the being, belonging, becoming scale, or the 3B scale.
So the aims of the project. So it was to create a virtual version of recovery through activity that was accessible to all despite those COVID restrictions, which were significant at the time, but are still prevalent, to provide individuals with early access to occupational therapy input. And this was really important, that it was regardless of their condition or their stage within the recovery process, and to improve the number of referrals to occupational therapy from other members of the multidisciplinary team. And this was a really important aim of the project, and this was to be supported by the development of a website and downloadable materials. So Recovery Through Activity really wanted it to strengthen the joint working between statutory and third sector services, and really making the best use of those community resources that we have around us. So how did we do? So our achievements to date. So we got the outcome measures agreed across Wales. We developed the protocols for delivering the virtual Recovery Through Activity group, and they were agreed across Wales. We produced information leaflets and posters. We increased the referrals to occupational therapy within the teams in which they were working, which was a significant achievement. Recovery Through Activity is being successfully delivered, which we are very happy to say, across an Iron Bevan, Swansea Bay and Hywel Dda Health Board. The website itself is still under development, but we are very lucky to be working alongside a service user with excellent IT skills. And there are plans to deliver between 1 to 4 virtual Recovery Through Activity groups per year per health board.
I'm going to talk you a little bit through the All Wales Recovery for Activity timeline and our journey throughout the project. And I'm going to be talking a little bit about the outcomes and the challenges that we faced throughout this time. Throughout this journey, there has been some challenges. Following identification of the outcome and the experience measures, it was the obtaining of the funding throughout throughout that. There was also very much kind of, as we set up the look at the website and the task and finish group, there was a lot of lack of funding for developing this website. And actually following that, we had a lot of service user involvement, which has very much greatly helped with the website development and is a feather in our cap for that co-production as we move forward. We also, as we move forward, had a lot of kind of information governance, and that task and finish group allows us to iron those out and to discuss and put those protocols and procedures in place. Virtual recovery for activity, though, allows us to create a more sustainable model of intervention, and I think it really does allow us to be delivered more centrally. And I think when we come back to the web, I think that is one of the biggest parts within that, is that actually allows us to deliver that more from a central base and from an all Wales perspective. From a positive element, it really allows us to upskill our staff and to really utilise technology and to allow these skills to move forward within our everyday practice, and actually how to transfer these skills that we've learned throughout this practice into other areas that we move forward. It allowed us to very much develop resources that can be delivered across all Wales. And I think the virtual recovery for activity provides us opportunities to work and deliver interventions in collaboration with third sector agencies, which leads me then very much on to the feedback, and as you can see here, the feedback that we've come back has been very, very positive. Service users have gained confidence, and actually, like I said, they've seen the more of the real me. And I think for us as a implementation of this group is very much around allowing people to connect more with their community and allow them to connect more back within the next steps of their recovery journey. And I think we've achieved that, as we can see from some of the feedback here, is that they've searched for things of their own accord, their own motivation, they've gained other ideas, and actually how they can carry this on after those groups and after those fruition. And I think for me, this feedback says a lot about the implementation of the recovery for activity program that we kind of set up.
That's great, thank you. So I need to introduce you first of all to the team. So I don't know if they can give a little wave. So we've got Nikki Thomas. Nikki's not waving, I can't see anyone waving at me. Christine Fairfax. Yep, hi Christine, and Jess Powell. There we are, thank you ladies. So from Howth, our University Health Board Occupational Therapy team. So as I said, please put your questions in the sidebar, but whilst that's hopefully coming through, I will ask you a couple of questions. Thank you very much for that, and for spending the time to be Bevan Exemplars, and also to come back and tell us more about your project. So can you tell us a little bit more about, you gave us a lovely timeline, but I'm just wondering if you can just update us even further really about what you've been working on and what results you've been getting. You need to unmute whoever decides to take that question.
Sorry, can you repeat the question for me again? Sorry.
Yeah, just a further update really on the results that you've been getting, and anything else you're currently working on.
Oh, I suppose it's quite a difficult one to answer that one at the minute, because we are an all Wales project, so I don't have access to everyone's kind of outcomes as of yet. But I think that for us is probably the next step really, is to really look at collating the outcomes that we've all been gaining, because I think everybody, as you could see from the timeline, there's been many challenges and positives to it, but I think we all as a health board kind of started off at a different time frame. So some people are very much way ahead and have finished maybe their first course, even looking at a second, whereas others are very even maybe just going to like a first couple of sessions into that. So I feel it would be a really good opportunity for us to kind of come together as a whole to really collate that information, collate that data, and to really utilise the outcomes that we really are seeing. And I suppose from a qualitative perspective, I know Christine will probably talk a little bit more about the informal outcomes that are coming back from our service users are just phenomenal. And
I can give some of the data if you like. I've got some, we've done sort of a consolidation of some of the outcome measures that we've got back from Swansea Health Board and an Iron Bevan, so I can go through those. So on the becoming a belonging scale, we've got 75% of participants agreed that they feel better able to manage their health from attending the group. 100% of participants said they, compared to when they began participating, that their quality of life has improved, and 75% of participants that have agreed that they've become less reliant on mental health services. One lady in particular, just picking up on that quality of data that Jess was talking about, said the quantitative data that Jess was talking about. One particular lady mentioned that she was ringing their crisis team daily, as well as her community mental health team support. She's now stopped doing this. She felt that she can attribute that to sort of attending the group and finding that self-reliance. In terms, we had a patient experience measure. So in terms of that, we had 100% of patients were satisfied with the virtual group they attended, and we had 100% reporting that they are more likely to do a virtual group rather than a face-to-face. We had some qualitative data back that people found that because they were in their own environment, it was actually a removing of a barrier which may have been in place before, whereas we traditionally offer services face-to-face all of the time, that because they could access it virtually, that actually removed that barrier for them, so they were able to sort of engage in their recovery and their care more. In terms of the resources we used, so 50% of participants found that the video clips that we used were extremely useful, 75% found that the handouts were extremely useful, and 75% found that the resource packs were useful. So some services are using resource packs to sort of supplement the delivery of recovery through activity. Some aren't. We trying to create a collective experience, I suppose. So some people are using third-party sectors, some people are using resource packs to sort of try and recreate that sort of face-to-face. You would all have the same experience if you were in the same room. So we're trying to sort of use that element and bring people together as a group so that they bond more, really. But that's sort of, even though our numbers are small, the impact of it already, you know, we're really feeling it in the health boards.
That's great, thanks both. And I think, you know, you touched really on brilliant patient feedback, and obviously it's a really well appreciated survey, but I think I'm particularly interested, you talk about obviously the virtual nature of it and how well that's been taken up. Obviously it's got a lot of future potential, virtual working. It's something that a lot of us been doing across the pandemic and trying to continue where you know it does work. Do you have any message to other leaders and others thinking about this innovation and how they could apply it to other service areas at all?
I think for me personally, I would say absolutely embrace it, absolutely use it, and like Jess was saying in the presentation, the governance was one of the biggest barriers for us. It was very, very difficult to initially set it up, making sure that everybody is safe online. But I think the potential for that technology, I can't see, I feel like it's limitless. Because I think for me personally, especially when you talk about patient care, moving away from that face-to-face, it doesn't suit everybody. Face-to-face working doesn't suit everyone, neither does virtual, so you need that blended approach. But I think if you offer it as an option, you are removing a barrier. People are more likely to engage in that care, maybe at an earlier stage, so that we are getting people through earlier in their recovery, getting them to engage, getting them more well. I think people, there's a lot of work that goes into sometimes getting people to face-to-face appointments or face-to-face groups, whereas this, you don't need that. They're very comfortable in their own homes. So I can't see a limit on it. I get very excited when I talk about virtual working, because I just think it's such a gift, I think, clinically. Yeah.
I think I couldn't agree more with Christine on that. I think there was a comment that was made by a member of our MDT that said you're actually capturing, you know, engaging with people who would never have even come into the CMHT. They were always like not attending appointments, not coming through, and it was pure anxiety and around their mental health. And I think this has allowed an opportunity to really work with individuals who we probably wouldn't have allowed that, given or that opportunity, or would have been much more further down their recovery journey. So I think it's been noticed not only as us but as a wider MDT as well, that these are kind of virtual working is a lot more easier to capture people within.
Yeah, I agree, and I think it's demedicalising the models as well, isn't it? As you said, sort of people with mental health conditions feel much more comfortable in their own homes as well. So, no, it's excellent. So I'm going to ask one more question. There's another question that I can't see, Tom, so I don't know if you can help me with that in a second. But you talked as well about it. Obviously, it's an all Wales approach. Why was that important, and what benefits has that brought for you?
Oh,
we're both like we're both going in. I think for us it allows a lot more kind of joined up working. I think that was a huge beneficial factor, and I can't sing about that enough really. Often we are quite siloed in our health boards, and we do fantastic good practice, but this was a really opportunity to come together and almost kind of standardize a practice, to make sure and ensure that we were all kind of working along the same model, working along the same ethos, all kind of coming together and problem solving, being able to bounce ideas off, being able to allow peer support as well, to link up with other health boards who are maybe a little bit more further ahead in their recovery for activity journey, to give that peer support to people who are actually a little bit more behind and starting off. So it allowed that peer support, it allowed that network, it allowed that ringing up Christine and bouncing an idea off as soon as possible. And I think it just kind of grew, and it grew to be a fantastic initiative. And I think it allowed us to really standardise what recovery for activity is and what we can offer as an occupational therapy service within that as well.
Definitely, and I completely echo what Jess said, and I think it allowed a quicker process because we all have our specialist areas, our specialist knowledge. We were able to bring all of that together in one place and all start off on a journey together. So rather than it being sort of maybe a drip approach, you know, other people then picking that up, we could all go at it together. And I think in terms of patient care, that's the dream really, isn't it? That we're not all reinventing the wheel, we're all doing it together at the same time. Yeah, so that was a massive plus about doing it across all Wales.
Great. So you can more sign up now across Wales. Sounds really good.
Yes.
I'm going to try and get this question. I have got one other thing I wanted to ask personally now, but Tom, what's that question? I don't want to click on the link in case I lose everyone.
Yeah, don't worry about that. That's fine. So we've got a question from Alice on YouTube, which says, is the online recovery through activity program being used in Ceredigion?
It should be. I think all health boards are signed up to it. They're certainly more than welcome to. Whether they have been in touch, I think from starting at the very beginning, I think every health board would have been invited. I think like Jess was saying earlier, lots of health boards are at different stages, and whether they've had the capacity actually to absorb that piece of work. So maybe they're at a different stage at the moment, but they're certainly sort of linked into the discussion. Yeah.
Great, thank you. My question was actually around the service user helping you to develop your website. I'm a full supporter of obviously using service users and their skill set, which personally as an AHP, my IT skills aren't as good as they should be. I'm just wondering, just tell us a little bit more about that, the benefits, how it happened. That would be great.
I think that they've come from Cardiff, they have, which is lovely. It was a very organic process. I think through the recovery for activity, kind of task and finish groups, we really wanted to look at how we could involve service users or get service user involvement. I think a lot of our service users took part in some of the kind of the artwork that you could see. I think people took part in kind of getting on board with that, and I think as the recovery for activity task force kind of developed, people were bringing in certain service users who had skills, who had expertise, who had knowledge, and we really wanted to utilize that as much as possible. So we are a little bit more behind in terms of peer support, and kind of a co-production in Cardiff, I'll be honest. So it was a long process to kind of go through that winded for us, and we worked very closely with our recovery college, and we worked very closely with kind of looking at how we could get the best resource for the service user to be involved. I would like to say, on a personal level, the service user flourished in that environment. The service user was from a forensic background. He had always loved web design, web artwork, very kind of anxious around face-to-face and kind of putting himself out there in terms of work, but one of his big goals was vocational, to get back into vocational elements of his role. And this allowed, that perfect opportunity allowed him to grade himself to be from a virtual platform, to dip in, to provide, to give his expertise, to then start to look at how we could work on that, upon that as his own occupational therapy goal within his own OT was working with him as well. And I'd like to say he actually has been successful in getting a full-time position as a web designer following that, and was able to use that as a kind of a network to really put some of his work out there. So
I think that's amazing in itself. You know, the programs of your project's great, but that in itself again is well, it's the true value, isn't that, of what you're providing and enabling people to do. So huge congratulations on that. Right, I don't think we haven't got any more questions. I don't think, have we, coming up? So is there anything else you wanted to say before we finish off this session?
Just to say that if anybody has any interest or would like any support, that, you know, we exist as an Always group. We're more than happy to support anybody to start this. We are a very enthusiastic group, so we'd be more than happy to share the learning, share the outcomes, and, you know, really share that with patients, really. Yeah.
That's great. Well, I think your colleague Nikki's been, bless her, has been trying to battle IT to get on. So apologies to Nikki Thomas for not joining you, but thanks very much to Christine and Jess for answering all those questions so well. So thanks for coming on to this this session. I think we're going to close now with a video message. Is that correct? Thanks again.
We're just going into the second VT, Lisa.
Okay, so for the second session now, is it?
Your second video.
We're going on to domestic abuse now, are we?
Yeah,
okay.
yeah.
All right, so sorry about that, everyone. Nothing like a well-oiled machine here. I know exactly what I'm doing. So thanks again for anyone that was attending and for our lovely presenters for Recovery Through Activity. We're going to move on now to our second presentation, which is Domestic Abuse Occupational Therapy Project in response to COVID-19, and that team is based in Betsy Cadwallader University Health Board. So thank you for coming, and if you've just joined us, please put any questions in the question and answer bar, and we will hear a bit more about the project now. Thank you.
Okay, hello, my name is Lucy Clark. I'm the clinical lead occupational therapist for the East Area Mental Health Occupational Therapy Service of Betsy Cadwallader University Health Board.
And I'm Kim Jones, an occupational therapist and experienced domestic abuse practitioner. The background to the project is that there has been a dramatic increase in the incidence of domestic abuse during the coronavirus pandemic. Domestic abuse is known to have an enormous impact on physical and emotional well-being and affects all aspects of daily life. The consequent cost of the economy is over £34,000 per victim per year in the loss of output, legal, social and health costs.
The aims of this project were to work at the domestic abuse safety unit base and provide upstream mental health rehabilitation and early intervention. We used a person-centred approach to help people identify goals that they wished to achieve, and used engagement with important activities and roles to develop lost occupational identity, embed self-management techniques and improve well-being. We used social prescribing across community and third sector partners wherever possible during the pandemic.
We were able to influence over 500 partners, informing them of the project. We delivered all pathways, processes and paperwork. 30 service users were seen over the 6-month period. 8 of whom were signposted to manage significant risk, and 16 engaged in occupational therapy, all of whom made significant progress. We gathered qualitative and quantitative outcomes for all 16.
Each person set between 3 and 5 personalised goals, a total of 68 across the cohort. Thematic analysis revealed 8 occupational themes. Occupational therapy interventions were aimed at overcoming the barriers to daily life and embed new habits into daily routines. A range of evidence-based interventions built self-management knowledge and skills, and these were harnessed alongside graded practice to progress towards each person's goals. Quotes from service users collated during the discharge review process evidence an improved ability to carry out each goal theme. Quantitative outcomes were measured with the Canadian Occupational Performance Measure pre and post occupational therapy intervention. We can see that all those who had completed intervention and had been discharged from occupational therapy had significant improvements with performance of their goals. Not surprisingly, those who had not completed intervention have not made as much progress yet. The same applies for the ratings of satisfaction with performance.
This project also has significant potential cost savings to the economy. The costs associated with employment, housing, health and the legal system are calculated to be over £34,000 per year for each victim of domestic abuse. And if we add the potential saving for all full cohort of 16 people, a massive total saving of £500,000 is achieved, representing a significant return on the £10,000 from the Elizabeth Casson Trust.
There were several challenges to the project due to the COVID-19 restrictions, for example, on accessing office space, being able to network with colleagues and provide face-to-face contacts. Service users had to prioritise homeschooling over appointments. Not all people had access to technology or privacy to use it for virtual appointments. Most community activities remained closed during the pandemic, and occupational therapy were unable to provide group work, face-to-face or virtually, reducing the numbers of service users seen. In addition, we note that the project could be more prudent if support workers were used for skill practice. Without this, Kim had to deliver all of the interventions. We have already had significant interest from the Department of Work and Pensions in supporting victims back into work, and they are seeking funding for this.
Great, thank you. Right, so I'm just seeing if they are online for the questions so I can introduce you. So have we got Lucy Clark? Yep, Lucy's
here.
Great. Kim Jones?
Yep, here.
Brilliant. Welcome. So thank you for this project. I mean, I think it's been throughout the news, isn't it, about the increase in domestic violence throughout the pandemic, and I think it's you know, when you see those qualitative outcome data, you know, you can see the impact that you're having. I'll start with some questions, but remember again, if you've got questions and answers, questions and the answers, you can put the questions and the answers, but if you've got questions, please put them in the sidebar as we go along. So you mentioned the link with the Department of Work and Pensions. Can you just tell us a little bit more about how this is progressing?
Hi, yeah, so the Department of Work and Pensions provide funding through job centres and through job coaches who are often mentored and supported through the disability support advisors. The way that it's funded is each job centre has to put its own business cases in, and so the Department of Work and Pensions are in the process of looking at business requests from each of the job centres to get this sort of live across North Wales at this region at least. So as you can imagine, that process is actually really slow. You know, so we don't have ongoing funding at this current time for occupational therapists to work within Department of Work and Pensions or actually within the domestic abuse safety units within North Wales. So it has been a pilot, and that pilot has come to an end. What I can say is that we've generated interest through Social Care Wales and the Research into Practice organisation, who are similar to Social Care Wales in equivalent in England, who want us to deliver training to occupational therapists who work within local authorities who maybe are having domestic abuse disclosed to them, more so than maybe social workers who, you know, maybe have stigma around their job title. And so there's lack of confidence amongst our local authority colleagues to be able to address, signpost, and even provide some intervention. So we're in the process of developing an education pack that can be delivered across the Research into Practice service in England and through Social Care Wales. So that's hopefully going to be happening in the next 6 months, that those sessions will become live. So, you know, we're stirring the pot, but nothing concrete as yet.
It's frustrating, isn't it, when you do a pilot and you get great outcomes, and then the good old funding issue comes to hit. But it's great that you're looking at other ways around that and how you can really reach the people to make the difference. You did mention actually that you trained or liaised with 500 partners and colleagues during the course of this pilot. That's quite an impressive number. How did you do that?
Yeah, that was through Kim. Well, maybe Kim wants to answer that actually, because it was Kim that did it.
Yeah, absolutely. It was when we initially started the pilot, we found it really important to let other agencies and professionals know what we were doing. So all over Wrexham, we organised networking sessions and went to speak to a host of professionals and individuals, just telling them a little bit about the service, how can they refer in, how it began. So we just wanted to get it, you know, out there to lots and lots of different professionals. So with, you know, creating the project as well, it was really important for us to tell people what was going on in their local area and how we as a profession could help individuals that had experienced the domestic abuse.
Yeah, that's great. And as you say, it's so important to advertise what you're doing, isn't it? So people aren't reinventing the wheel, or they know where to refer into. Just talking a little bit more about outcomes, can you give us an example of how you saw lives change with this intervention?
Absolutely. I mean, some of the case studies that are on the website were really vital and really eye-opening. I worked with a young lady who's had not long left the relationship, and she was on the edge of losing her job due to not being able to engage in a job, not being able to function, having low mood. And while working with her and doing the interventions, we set goals, and you know, she was really proactive in setting the goals around her workplace. And with over the 3 months that we worked with her, you know, her work could see that she was being more proactive, she was engaging better. So it was just changing her focus, changing the way she was looking at moving forward, looking at the way that the relationship had affected her, and how she could engage better in the workplace.
I think our the full presentation, which is there's a link to the full presentation on the webpage, is highlighting about prioritising, just looking after yourself, just getting up, getting into a routine, getting into the shower, getting some food, getting some exercise, and using strategies to overcome overwhelming anxiety. So people had improvements in being able to get to the shops, being able to make connection with their friends, being able to you know, keep themselves and their home clean, actually making a home instead of just, it's really the living not existing side of things, instead of just surviving and feeling like a prisoner inside the house and hiding in the home, making it comfortable, making it enjoyable, connecting with others. So we were targeting every aspect of daily life to improve quality of life, and that came through very, very clearly in the qualitative comments that we got. You only got a snippet of them there, but from our service users. So it was really satisfying work to be engaged with.
That's great, thanks. So I nearly frightened myself and I pressed leave instead of unmute, but it's okay, I'm still here, I think. Can I ask a little bit about, please keep the questions coming, otherwise you just got my questions and I'll probably bore you all. Can I ask about the liaison with other professionals? So how you were received, I suppose, as OTs going into an area that wasn't necessarily, you know, sort of a well-known area for OT to go into. How was that? How was the MDT working around that?
Kim, do you want to talk about your connections within the domestic abuse safety unit?
Yeah, it initially started, my background was working in the field of domestic abuse. So when I seen what occupational therapy could do for the individuals that had experienced the domestic abuse, it was very much going in and telling the professions who worked within the domestic abuse all about occupational therapy and how it works with the service users. And then when we were talking to occupational therapists, it was how they could fit their self-care, productivity and leisure ways of working into the world of domestic abuse. Because what we found is when the individuals left the relationship, they almost like lost and needed that intervention to help get routine, structure and boundaries. And it was really interesting how both were really positive and both took on board exactly what. So the world of domestic abuse took on occupational therapy, and the world of occupational therapy really engaged within the domestic abuse side.
And we had you know, some people were signposted onto primary care services or to GP practices, and some people were actually already open to secondary care, so sort of liaising with community mental health teams or tier 1 services. Some people, it was about liaising with their job coach, with their work coach. So, you know, people in all walks of life suffer from domestic abuse aren't necessarily open to mental health services, but that signposting into community resources and community supports was to know that there is support around from organisations like Mind and other local charities that provide support. So it's really, the networking is absolutely key, and it was generally well received. I think the comments back from colleagues and professionals were really positive, and again, those could be seen on the website if you want to take a look.
That's fabulous, thank you. So my last question actually is what you would say to someone who's thinking about taking this innovation forward for their team.
Do it. The first thing. And we are really happy to support with the sort of nuance of applying occupational therapy skills and practice into this sort of specialist area of domestic abuse, because it is about adapting what you do, say what might be more routine within mental health services, into this arena. And that's what the training that we're putting together is going to be looking towards. And you know, I think occupational therapy can help connect all those different providers of supports together by placing the person at the centre and getting the relevant services to work together to support them. So it isn't all about just the person doing their own work on themselves, although that's absolutely key, or it isn't about the occupational therapist doing the work with the person. It's about harnessing the whole of the care and health and care system and the third sector and community support and those community assets that might be actually the patient's family, and thinking with the person what it is that they need to do in order to make that progress. So yeah, I think be bold, step out, and be in touch with us if you want support with it.
That's great, thank you. So I don't have any other questions. Tom, we're not missing any, are we, in YouTube or, oh, hold on. Yeah, we've got one.
We've got two questions, again from Alice on YouTube. So the first one is just to understand, is the cost saving you stated based on the entire economic impact of domestic abuse? The intervention supports victims' recovery, they don't erase domestic abuse.
Yeah, the impact, the cost of 34,000 plus for each person, there was a really detailed breakdown of how they came to that figure. And you can imagine the sort of health economics is how complex and difficult it is to do that. So it was a paper from a study that was conducted in 2017, published in 2019, about the cost, and it is the cost to the economy. So about lost output, so people's job roles, and if they're on having sick days and not being able to work, the effect on the economy of those lost work days. It is about the cost for physical harms, psychological and mental health harms, and the impact of that within the health service. It's about the impacts of the courts and the police, with people who are kind of returning back to an abusive, in the cycle of abuse, returning back to abusive relationships, maybe 6-7 times before the relationship is finally over, and bringing that earlier to reduce those numbers of returning into an abusive cycle, so that the police aren't being used again, A&E isn't being used again, GPs aren't being used again, the courts aren't being used again. It's the total cost of the economy. And if you're empowering individuals to be able to manage their life, to be able to assert their right to be treated with dignity and respect, and not to be in abusive, to move away from abusive relationship, then we're looking at the cost saving to the whole economy, not just to the healthcare system, because we're treating people as a whole being. So yes, that's where that's come from. I hope that answers the question.
Fabulous. Yeah, from my perspective it does. And there's a second question again from Alice on YouTube. So is everyone who participates in the programme safe before they start?
Yes, that's why the occupational therapist is actually based within the domestic abuse safety unit, which is the provider of domestic abuse services, you know, in the commission to do that. So people are signposted or can self-refer, or referred into domestic abuse safety services, and they have separate to occupational therapy a crisis response team, one-stop shop, you know, where people can phone in. They have support, they have counselling, they have support to people to go to make connection with the police, support through the courts, and probably Kim could talk more about that. So the referrals were received only through the domestic abuse safety unit, and in our networking that we were talking about before, the first thing was to just educate health providers across all sectors about that service, because it's underused, and domestic abuse might be under-recognised, and then signposting doesn't necessarily happen. So, and then from within the service, people, you know, it was a new offer of health intervention, because of course the staff within the domestic abuse safety unit are not health practitioners, they're not healthcare providers. So we were able to provide a screening and triage to say, actually, you do need to go to your GP, you do need to make touch with your, you know, request a referral into the mental health measure if that's required. So we were able to do that sort of triage and screening. And I have to say that domestic abuse can often be comorbid with other conditions like pain. You know, we know anxiety and pain are linked together. People living with other health conditions may not be accessing healthcare because of their overwhelming fear of being out in the community. So as occupational therapists, we were able to do that as well. You know, if somebody needed some guidance on managing fatigue, pain, or managing breathlessness, we're able to do that little bit of signposting and onward referral where it was needed.
That's great questions, Alice, and well answered, ladies. I think Alice might be getting in touch with Lucy and Kim by the sound of things. So go for it, Alice. Sounds great. Any other questions?
Sorry, Lisa, just one more thing from me. Am I right in saying that the website is being updated as we speak over the next couple of days with further information?
Yeah, thank you for that. Yes, with the project and the outcomes that we published for the Bevan Exemplar in June were based on a project which came to an end of funding at the end of March. Now, we were actually able to extend that to the beginning of August. So some of the people where you saw those charts where intervention wasn't completed and we had some really significant outcomes on a standardized measure like the Canadian Occupational Performance Measure, and then there were people who hadn't completed and so their outcomes weren't as clear. We now, of course, the project is complete. Everybody who was worked with has completed or withdrawn from intervention. So I think our numbers are that 20 people completed intervention, 2 had a little bit of input but kind of withdrew before completing, and then 8 were onward referred, weren't appropriate, needed input from elsewhere. So the outcomes from the whole 20 who completed intervention are all statistically significant, and so we can add that number, and I've just totted it up. It now comes to a total cost savings to the economy of £680,300. So massive cost savings because of the project, and unfortunately it's now come to a complete end. So 20 people have benefited, 8 have been signposted on, and you know, we hope to see if this can be re-established across Wales, across the UK as we go forward.
Absolutely. Another question, Tom?
Yeah, a question from Versha Sood. Do we work with some third sector or charitable organisations like Welsh Women's Aid?
Absolutely. Welsh Women's Aid is a domestic, I think the Domestic Abuse Safety Unit in the Wrexham and Flintshire area had kind of you know, really close partner with Welsh Women's Aid and taken on the kind of front door for Welsh Women's Aid. So as sitting as a health professional within the Domestic Abuse Safety Unit, then yes, anybody who was coming through the Domestic Abuse Safety Unit who needed those kind of refuge and aid through Welsh Women's Aid would be, you know, already receiving that input. And then if there was a key worker who was working with a person who was receiving occupational therapy, then there was liaison as appropriate. I don't know if you've got any case examples of that, Kim, where you were guiding Welsh Women's Aid about intervention.
No, when we first started this project, it was the Domestic Abuse Safety Unit that had recently taken over the Welsh Women's Aid. So initially it started with Welsh Women's Aid and then got transferred. But like Lucy said, it was a really strong multi-agency working. So if we were working with somebody and they'd gone into crisis, then we would work with Welsh Women's Aid to see if we could get additional support. So we worked with a lot of third sector organisations as well.
That's great, thank you. It's such a shame, isn't it? Funding. Oh, I wish you all the best.
Such a shame. Thank you.
I think that's the end of session 1. We are 6 minutes early. Tom, I don't know what that does to your timetable, but just to say thank you for everyone that's tuned in either via the link, via YouTube. Thank you again to Lucy Clark and Kim Jones for sharing their great work and for you all engaging and asking great questions. So please stay on for the next session. Are we going straight to it, Tom, or are we going to wait till 10:45 just for people to know?
I believe we'll wait till 10:45 till then.
So you have a 5-minute comfort break. And then Angela Bell will be back chairing session 2. So that's it for me. I will be quiet. So thanks again all. Thanks for joining us.
Hi, good morning everybody. I'm Angela Bell. I'm the Interim Assistant Director of Therapies and Health Sciences at Cumtath Morgannwg University Health Board. Welcome to session 2 of the AHP Exemplar Symposium. Just want to say thank you for joining us this morning if you've just joined for this session, and welcome back from your comfort break for those who've been with us since 9:30 this morning. Thank you to the Welsh Allied Health Profession Committee for inviting me to chair session 2 today. I'm delighted to be here. It's absolutely the space that I love to be in, that learning and sharing, the opportunities to reflect on how we work and how we can continually improve. So without further ado, I think I'd like to pass straight to the first presentation, which is looking at Healthy Start vitamins and increasing accessibility for eligible families. Here we go.
Okay, thank you to the Bevan Commission for the opportunity to share our work today. Our project focuses on the Healthy Start vitamins and specifically exploring the barriers and solutions to increasing accessibility for eligible families across North East Wales. Leading on the project is myself, Andrea Basu, and Sarah Powell-Jones. So by way of background, it's essentially a UK-wide scheme that provides eligible pregnant women and families who have children under 4 with weekly food and vitamin vouchers. And the Healthy Start uptake in the last 12 months has varied between approximately 53 and 62% as the Welsh average. Now, specifically, the Healthy Start vitamins provide key nutrients such as folic acid and vitamin D, which are recommended for supplementation in these key population groups. Vitamins are typically distributed via midwifery and health visiting teams. However, during the COVID pandemic, this has impacted on access for many families, and at the same time presented an opportunity for us to explore some additional points of access, particularly in supporting ongoing provision of the vitamins beyond the initial 8-week supply. So our principal aim was to increase accessibility of the free vitamins for eligible families across Wrexham and Flintshire by scoping the journey of these eligible families in getting the vitamins, clarifying the local distribution arrangements that are in place so that we can then identify some possible solutions to improve access and hopefully consequently uptake, implement those solutions and then cascade clear and consistent information about how to access the vitamins themselves. Okay, so looking specifically at the family's Healthy Start journey. The family first hears about Healthy Start, usually via their midwife or their health visitor, but they may also find out about the scheme through family information services or through Find Start family centres. So first of all, the family completes a paper application form, and they can return that free post to the national team, at which point their eligibility is assessed. Once assessed, if they're considered to be entitled, every 8 weeks, the family is sent a green voucher in the post, which they can hand to their midwife or health visitor in exchange for the vitamins. Arrangements for distribution are different in Wales compared to other countries, England and other home countries, and the responsibility for distribution here lies with our health boards. And so we felt there was perhaps an opportunity for us to engage community pharmacy, particularly since they were an accessible and easy point of contact during the pandemic.
Okay, so moving on to look at distribution of the vitamins, we wanted to clarify and identify local distribution methods. So at project inception, we found that local pharmacies were not particularly engaged in the scheme. We carried out a local audit with all the community pharmacies in Wrexham and Flintshire, and it identified that none at the time was stocking the vitamins. There was confusion regarding where families should access the vitamins. COVID-19 and reduced contact with health professionals had an impact on usual routes of access to the vitamins also for families, as many family centres and clinics were essentially closed. There was also concerns that eligible families do not return or request follow-on vitamins after the initial 8-week supply. So
solutions, what did we do? We did some training. So we produced a virtual training package with audio to support all pharmacy staff to increase their awareness of the scheme, the vitamins, and essentially what we were going to ask them to do. So in addition to supplying the vitamins to families, pharmacies also agreed to actively promote the scheme and hold copies of the Healthy Start application forms for any families who were inquiring about their eligibility. And so 279 staff members have accessed the training package to date. This includes pharmacy staff from all the 12 participating pharmacies and a range of other key health professionals. We also wanted to cascade clear information to families on how to access the vitamins via promotion. So alongside the training we provided for key stakeholders and health professionals, we created a number of social media posts focusing on using Facebook and Twitter to promote as much as we could the new access points for the Healthy Start vitamins. We achieved well over 42,000 views. In addition to the social media pages of the organisations listed, we were also able to share with local community Facebook pages to increase the reach as much as possible. And finally, it's always good to hear about what impact the project has had on others, in particular our partners and ultimately the Healthy Start families themselves. So the pharmacy counter staff stated, parents who have come in with the vouchers say it is great to know where they can now come to get their vouchers. It has made it a lot easier for them. They are telling their friends too, and we have handed out the application form. And then the Healthy Start parents stated, I'm really glad I can pick them, the vouchers up from here now. It makes it a lot easier.
And so our next steps, well, the project is still very much ongoing and we plan to audit next month all 12 pharmacies. Early indications are suggesting that we've uplifted the uptake of the vitamins by approximately 50%. However, we are acknowledging that we've been working on the project throughout the pandemic, throughout the period of working. So perhaps not being able to train or promote the project face-to-face with stakeholders and the public might have initially been a disadvantage, but using virtual training was efficient for our partners and us, and the engagement we were able to achieve with social media has been good, and we've been able to reach senior managers and internal decision makers through using things like Microsoft Teams meetings quite quickly, and that's helped to get through a number of roadblocks and progress at some pace. So we very much want to evaluate the experience of working with our partnering pharmacies and how we can sustain and extend provision across the health board and indeed other health boards. And like today, we're sharing our learning and key to engage as much as we can with fellow colleagues to see how we can extend this work.
Great, thanks for that. It was a great presentation. Can I just welcome Andrea Basso and Sarah Powell-Jones from Betsy Cadwell Unity Health Board. Thanks for joining us this morning, ladies. And just a reminder to the audience, if you've got any questions at all, pop them in that sidebar in the Q&A and we'll field those onto Andrea and Sarah. I mean, phenomenal. I mean, those figures, 279 people trained, 42,000 views for your information. That's some engagement. Can you just talk us through where you even started with that and what you think led to that achievement?
Gosh, I mean, I think in fairness, the time that we had on the Devon Exemplar, really it was all about the engagement. It was all about, as we said in the presentation, really forging those links with stakeholders, many of which we knew we were in contact with to some extent, but just hadn't had the focused time really to look at this in any great depth. And you know, the pandemic presented an opportunity for us to consider working with a different partner, particularly community pharmacies. So I think in fairness it was almost the ability to use social media, and a lot of the local sort of Facebook community pages were things that we were just ploughing ourselves to do, more so than perhaps we had done before. probably in part because we've become more confident to use that form of communication, and also because, you know, as a team, we're very much about getting out there and meeting the public and engaging that way face to face, and clearly, you know, we couldn't do that, but it was phenomenal. I think we were really surprised to see the number of views that we'd achieved across the board, and that was from a range of platforms that were sort of, you know, the health board, communications, like I say, local community Facebook groups, family information services pages. So yeah, we were delighted with that, but I think, you know, we're not resting on our laurels. I think we know going forwards we're really just starting out with this, and like we said in the presentation, we plan to do an audit in July, but I think we've recognised that because we've really only got the vitamins into the pharmacies from April, you know, we need a little bit longer to assess the value and the accessibility that's actually taking place. So we're carrying on till the end of this calendar year, and not least because we're going into winter. Vitamin D is one of the key nutrients, and already Sarah, who does a lot of the groundwork on this, I have to say, has identified that more and more vitamins are being taken up in the pharmacies just in this last month. So I think we're going to be doing a lot more of this promotion as well going forwards to hopefully get a good result towards the end of the year.
I think from my point of view, engagement via social media has been invaluable, but moving forward, getting back to face, will it also increase our engagement, because we can include it in a lot of like sessions that we do out in the community, and promote it, you know, face to face with people, and we've got a real clear vision of what we can tell people now, which I think's one of our best outcomes of the project. We can signpost people clearly, effectively, and know that they're going to be getting those vitamins. So yeah, but I do think social media has played a part in our lives, and it won't actually stop now. I think we'll use it in conjunction with face-to-face work that we will do forever and a day, you know, because it has been a really effective way of communicating with community members.
Yeah, thanks, Sarah. And I think that hit on a good point that I'm sure will resonate with most of the audience. It's that blended approach, isn't it? We're moving from that traditional model because we were forced to. We've embraced the new technology, but now it's that step back, reflect. You know, is it the combination of the two that's going to give us the best possible outcomes? So some really good learning I'm picking up here. And also what I heard from you too was that needing to give yourself time in order to be able to evaluate that. Sometimes these things can feel frustrating because you've got the vision and you want to deliver it, but actually that the importance of actually stepping back and thinking, you know, we need some time for data collation is actually fundamental, because being able to share those outcomes is what's going to get that spread and that scale and that future engagement, isn't it?
Absolutely.
Yeah. Have either of you got any particular sort of individual stories or something that really springs to mind that really brings this project to life for the audience, and a particular conversation, something that happened with an individual? Have you got anything that just springs to mind that really sort of cemented this project for both of you?
Shall I go, Andrea?
Yeah, you go first.
For me, it was a really good moment, and it was only a couple of weeks ago that it happened, but I'd managed to get back to face-to-face delivery of some of our you know, sessions with community members, and as always, I brought up Healthy Start in the conversation, and one of the mums said, oh, I just throw the vitamin voucher away because I don't know what to do with it. So this was a clear moment for me that the project is success and we need to be doing this. So I was able to tell her that just up the road, the local pharmacy that we'd engaged with was supplying the vitamins now, and she could go there. I phoned the community pharmacy a week later, and that very mum had been in and talked about the engagement with myself, and she'd picked up her vitamins. So to me, that says it all, really, that we are making a difference, but we want to do it on a bigger scale if we can. But it's a start. So that for me was a really good moment. Other good moments is, as I say, I'm talking with all the community pharmacies at the moment, and they are saying that parents are coming in saying, now we know where to get these vitamins, and hopefully in the last month we've seen that they are revisiting. So yeah, that's my win from the project.
Thanks, Sarah. Have you got anything, Andrea?
I mean, that story is just so powerful, isn't it, for us? I think when I think back to where we started off, and we audited 59 pharmacies in our East area, and none was stocking the vitamins. And yet we know, and this is no, you know, detriment to our colleagues working in other professions, but, you know, parents were being advised to go to pharmacies because actually that's something that can happen in England, but wasn't available here. And so there was a lot of, you know, a misunderstanding being given to families about where to go. And I think for us, the contacts that we've had with midwives and health officers since, and the positivity around the clarity that we've been able to provide and the provision that we've been able to provide has been really good, and been reassuring. And they really just keep saying to us that they want this to continue. You know, it won't diminish their role in terms of perhaps giving out that initial pot, but 8 weeks later that pot runs out. And what's typically happening is parents are not going back for subsequent pots because they may not be due to see their health visitor again, and they may not well be motivated to pop along to the clinic or make that phone call, but they may be going into their community pharmacy for various reasons. And so it's just making it easier for people and more accessible. So that for me is another really important you know, story, really, from the beginning to end, just showing what we've been able to achieve. And it's, you know, quite simple, but the conversations and the red tape, in some respects, we've had to work through to get there. It's been less easy.
Yeah, I completely empathise with you there. I mean, and I think it's a really good example of when you've got that local knowledge and you can signpost to that. You know, that was so powerful, Sarah. You know, I knew exactly which pharmacy was local to the lady, and I could direct her. Which brings me to my sort of further reflection on what next. Spread and scale. Obviously, you know, you've mentioned your evaluation based on 12 pharmacists and nearly 60 in the East area. What are your thoughts on taking this to the next level so that we can have a national approach here?
Yeah, we are getting interest with, you know, being asked by national colleagues, can we speak to you about what you're doing, which is really heartening for me, because I know that Healthy Start is mentioned within key strategies like Healthy Weight, Healthy Wales. So we're really keen to speak to national colleagues. In the first instance, we're really keen to see how we can spread it across our entire health board. And I think we'll be working, you know, steadily towards that as we get towards the end of this year and the beginning of next. But Sarah and I are still on the big push to get as many vitamins given out as possible. So the things that we've been engaging with really since has been, Sarah's worked really well with our comms team, who are working on our internet pages, completely revamping them for the health board at the moment. And we're literally about to go live with some Healthy Start pages on there, which are looking great. So we're, you know, that's a really good sign of progress. We've got a regional link with community pharmacies as well, who is so supportive and actually came to us saying, right, what other pharmacies can we get on board? And there's a couple of areas that we know that would benefit from having, you know, a pharmacy where we know there's a lot of Healthy Start families that are beneficiaries. So Sarah's working on that with their contacts, and we're hopefully going to extend the number of pharmacies by another 2 in very key areas. So we're quite excited about that. We're planning some local radio promotions. We've looking at things like Sarah recently engaged with Home Start as an organisation, a charitable organisation. Again, just being able to do more face-to-face work to complement the social media work that we've been doing. But our ultimate plan is to pull together a final report, a paper to really sort of highlight how we want to take this forward across the organisation, and have those national conversations as well, both, you know, sort of on a government level, because we know that they're looking at the scheme in different ways. You know, there's plans to digitalise the scheme that's been looked at in England, so we know we're going through a period of change with the scheme, but also looking at within our professional groups as well, so looking at, you know, how we can share practice amongst dietitians on this, as well as other fellow groups such as health professionals like health visitors and midwives, of course. So lots still to be doing and is being done, but we do want this opportunity to be spread. We think community pharmacies have really embraced this. They've taken it on, not as part of a, you know, an enhanced contract, as part of their public health responsibility at a time when they've been super busy. They've been asked to take on extra things during the pandemic. And they've been brilliant, and Sarah's had such you know, great engagement with them that I think we can really look at this. It's possible. It really is doable.
Yeah, I think with the community pharmacies point of view as well, it has been not a massive amount of work for them, but they recognise how important these vitamins are for pregnant women and children, so they're happy to do it. But you know, it's been one of those things where they've helped us and we've helped them very much. So, yeah.
That's brilliant. That's true collaboration then, isn't it? And that's the way forward, isn't it? Because we can't keep doing what we've always done. We've got to do something differently, haven't we? So it's a really good example of that. Tom, can I just check with you, have any further questions come through on any of the channels?
No further questions. Just, I know we're short on time, but a quick one from me. What advice would you give others looking to try out and test similar innovation projects?
Well, don't be scared. I think probably is the first thing I would say. And I think just to, I mean, we had quite a clear idea about what we wanted to do, and we knew the topic area, we knew the scheme really well, and we almost knew the frustrations, so we were ready to go with an idea. So I think if you've got a clear direction and you're passionate and you're not scared of, you know, I mean, the sponsor that I had, our exec sponsor within BCU, was awesome. He was like, right, you know, you might rattle a few cages, but you kind of need to do that to get to where you want to be. And he was absolutely right. So I think being brave, obviously remaining professional, but being brave, to knowing your topic. And I think, you know, people have every chance of succeeding. So I mean, that's what I would say. I don't know what Sarah might add.
Yeah, I'd say exactly the same. Know your topic. I think that's where we were confident, weren't we, Andrea? We kind of knew it inside out. We just knew what we wanted to do with it. But also keeping it simple. Don't get too complicated. Have a clear goal, have a vision, and kind of stick with that. I mean, you have to change slightly as the process goes along, but have that fundamental goal. And ours was accessibility of the vitamins, and I think we've achieved that. So yeah.
Okay, brilliant. Thank you. So thank you, Andrea. Thank you, Sarah. I think some really strong messages there, and we're getting a theme of being bold here. So we'll hold that, we'll reflect on that, and what's going to enable us to be bold as we move forward as a group of AHPs. Okay. So now on to our second part of this session. We're going to be looking at a food-wise in pregnancy programme.
So my name is Lisa Williams, and I coordinate a community nutrition programme in Wales called Nutrition Skills for Life, and it aims to build community capacity to support healthy eating. And we do this by providing accredited nutrition skills training, resources and practical support for staff from health, social care, education and third sector organisations, and for community peer leaders and volunteers, so those who really know communities far better than we do as professionals, and enable them to encourage and support healthy lifestyles. So as we know, well, 61% of adults in Wales are above a healthy weight, including 25% of adults with obesity. And we know that 1 in 4 to 5-year-olds start school each year above a healthy weight as well. And these rates of obesity are predicted to increase to 64% of the population by 2030. And we need to change this trajectory. And pregnancy is a powerful motivator, a teachable moment, and an optimal time in life to make lifestyle choices that can positively impact on health and well-being of women and their families. And being a healthy weight in pregnancy reduces risk of gestational diabetes, high blood pressure, preeclampsia, caesarean section for women, and lower risk of childhood obesity for infants. and working with midwifery and health visitor colleagues and Flying Start families in Cardiff and Vale, we developed a 6-week healthy lifestyle and pregnancy programme, Foodwise in Pregnancy. Dietitians train community workers to deliver the programme, providing a more cost-effective model, with support workers and assistant practitioners working at the top of their licence. And through our early discussions with Helen and Sean in the Bevan Commission, we were encouraged to consider a more peer-led model rather than a professionally led approach, and to include a greater focus on physical activity. So our aims were to improve access to support for healthy lifestyles, to deliver the Foodwise in Pregnancy programme, and to provide accredited training for community facilitators and also for our midwifery colleagues. And we've delivered the programme to a small cohort with successful outcomes, and we aim to test this model with more women and partners and to make recommendations for All Wales rollout as part of Nutrition Skills for Life. What did we do? Well, between October 2019 and March 2020, we engaged with partner organisations, with midwifery colleagues, with Families First and Flying Start, and also with families through a reunion event from previous cohort. We developed promotional resources which had the QR codes. You can see some of those on the screen there, posters and stickers that went inside the maternity handheld notes. We also surveyed women's views about the number and durations of sessions to see if that was right, whether we needed to make any changes there. And we also wanted to explore with pregnant women how they would prefer to access this information. As the numbers attending programmes, we knew there was a difference with this programme compared to other community-based programmes we run. The numbers were always relatively low, but we began to also think about, and little did we know what was to come in March 2020, but through the work with the Bevan Commission and meeting our fellow Bevan exemplars, we've started to think about things like apps and things like digital technology and other things that might be we might be able to develop. So these are some of our outcomes. I won't go through all of these in details because of the limited time available, but we use results-based accountability to evaluate our programmes, to look at how much we're doing, how well we're doing, and who's better off as a result, in terms of, crucially, who's better off as a result. Pregnant women reporting feeling more confident or much more confident to manage their weight since attending Foodwise in Pregnancy, and they felt they'd been able to make changes to their own diet. And then COVID hit in March 2020, and as public health dietitians, many were redeployed to wards and into the Dragon's Heart Hospital in Cardiff, and we also worked with local authorities and the Welsh Local Governments Association to support emergency food provision for people who were shielding and self-isolating, and the provision of food for families, usually in receipt of free school meals, so that they could continue to receive their food-related benefits. As I mentioned earlier, COVID-19 has actually presented a huge opportunity to us to accelerate digital development of our All Wales Community Nutrition Programme. So we embarked upon our digital transformation journey. But then in August 2020, health boards were asked to submit plans for utilising Healthy Weight, Healthy Wales funding available up until the end of March 2021. We secured that funding, and we were then able to progress with the development for digitalisation of nutrition skills for life.
Sorry, Angela, that was quite an abrupt end to that one. Sorry.
Okay, thanks everybody. Sorry, there was a bit of an abrupt end there. I'm not too sure whether that was my Wi-Fi, my end, but apologies for the abrupt end. But welcome, Lisa. I forgot to say when I began sharing, I am actually a registered dietitian, so it is absolutely phenomenal to see these dietetic projects coming to fruition. And I know that Lisa has been the National Nutrition Trainer Facilitator for Nutrition Skills for Life for many years. She's so experienced. She's based in Cardiff and Vale Health Board, but the impact of what she does influence across the whole of us nationally. So welcome, Lisa. Just a reminder to the audience, go on, don't be shy, be bold, get those questions in. Otherwise, like Lisa Lovegould in the first session, you're just going to get mine. Oh, wow. You've obviously alluded in that presentation, Lisa, about how you've changed your way of working. How has working with the Bevan Commission on this project changed your way of working, would you say?
Thanks for that, Angela. And I guess that's the point that the presentation got to, actually, because we started off doing something quite different. Well, looking at Foodwise in pregnancy, because that was a specific programme of ours where we wanted to improve engagement with women in pregnancy. Of all of our programmes, that was the one where we found numbers, the uptake was lowest. But obviously our programme, we were in cohort 5, so we started in October 2019. And so you heard about the work that we did between October and March before the pandemic hit. But it really meant that in terms of our way of working, because obviously, as you said, and for a number of years we've been working on our project, which has been face-to-face delivery, building that capacity in communities by training up those who've got those natural links with community members. And so we had to shift, we had to transform to delivering, like many others, to delivering that through virtual delivery. So it meant really we were ahead of the game. We'd already started to think with Foodwise in pregnancy about the development of apps, the development of sort of online digital versions, online learning, and it was fantastic to hear of some of those technology projects that were included in the Bevan Exemplar Cohort 5, and through the way in which the sessions are run with the Bevan Exemplars, just having those one-to-one conversations with colleagues about what they were doing was really, really inspiring. And so we were sort of, as I say, ahead of the game. It meant that through things then like the Bevan Health Hack, we were linked in with an industry partner quite early on, but the big issue for us was funding. So when we were able then, I guess the other thing was the confidence to do things like go out and ask directors of public health from every health board if they'd consider giving us a one-off contribution towards digitalisation. We did that, we got the funding, and then we embarked upon the whole sort of tender applications, multi-quotes that we needed to do to then begin that work, which really started then in full flow at the beginning of this year. So I think it's accelerated that transformation. For women that we work with, it means that specifically for Foodwise in pregnancy, we will now have a Foodwise in pregnancy app. We're due to test that in the next few weeks, actually, with a small cohort initially, so that first trial phase. And it does mean then going forward, we will have a digital version of Foodwise in pregnancy sessions. So those 6 weekly sessions, we can run those virtually should we need to, or in areas where perhaps those groups aren't viable, so more rural areas can deliver those virtually. And we will still have the face-to-face course that we had previously. So hopefully it means there's more choice for women to be able to access that information, and possibly reduced cost for provision because we haven't got to hire rooms, all of those things, travel costs, etc. And we're training up maternity support workers as well. So, hopefully we'll be able to train more maternity or dietetic support workers to deliver the virtual programmes which will accompany the app.
Thanks, Lisa. Yet another example of being bold, going out there for the funding and the ask. But I think that's, there's something to be learnt there, isn't there, with regards to actually when you can prove that there's going to be everybody contributing in order for the national impact. That is so powerful, isn't it? And for a small profession to be working on something like that, I think it's even more important, isn't it, to be able to get that spread and scale. Thank you. I suppose my other reflections really, probably from a personal perspective, thinking about how long ago we trained and how work is so different now. How did it feel? How did you navigate your way through all of this technology and getting the apps? And any tips, any key moments for you that were real key learning?
Oh gosh, I think already having started to develop some of those relationships, I guess, with the experts. We're not IT experts, and I think having had the opportunity, as I say, through the Health Hack to meet industry partners and start those conversations was really valuable. So I think it was overwhelming, the amount of work, because as you know the program's been running for some time. We have 2 accredited courses, so there are 19 sessions, all of which needed to be developed as e-learning sessions across those 2 accredited courses, 2 apps. We've got Foodwise in pregnancy, but also Foodwise for life. for the general population, so a second app. We've also got a website in development, and also 5 short courses. Those level 1 courses will have teaching resources then that can be used online. So the volume seemed a huge amount really, and it was just chunking it down, and building those relationships and connections and those partnerships has been, is essential. So working with, as I say, industry partners, we've got 2 industry partners on board, working with NHS Wales Shared Services Partnership, the digital technology team, that's our platform where all our digital resources will sit. We've worked with legal services within the Shared Services Partnership to make sure we've got all things like terms and conditions and all the sort of legal things required for apps in place. And that was after all of the work that we did to develop the tender specifications, the multi-quote specifications, and evaluate those. So it's been a lot to do, but we've learned so much, and we're sort of keeping our end users, if you like, the people that we work with at the heart of all of that, so that we can continue to reach people in future and restart the programme fully.
Gosh, I mean, that's just mind-blowing for me. Just all of this, it's not about the dietetic knowledge and the content. It's so far wider than that, and I suppose having cohorted the sessions today almost into sort of professional groups, which is understandable because of people's limited time, I am thinking that if we took the nutrition content out of this, all of that learning that you've had, Lisa, could be applicable to any AHP that's looking to innovate and change. So I think being able to dip back into recordings and pick up on this is going to be such a valuable part of today's symposium. So thank you. Tom, are there any questions from you or from any social media platforms coming through?
There aren't, no, but just to say, a really, really interesting project, and as has been said already, there's so much learning that can be drawn by, I think, from all the exemplars that have been through the process, and it'd be really interesting to understand how we can sort of take this learning forward as an alumni, as a cohort, and draw upon that on a pan-Wales basis, so we can really support change from the ground up, as we're seeing here today.
Thanks, Tom. Lisa, have you got any final comments that you want to give to the audience today?
Well, just thank you for the opportunity, and thank you to the Bevan Commission for all the support and the contact that it gave us. It has helped us restart our programme. It meant that over the summer we were able to train staff to deliver the school holiday enrichment programme. So we've already restarted, and this summer saw 190 SHEP, school holiday enrichment programme cohorts across Wales, providing places for about 8,000 children. So and we hope that now will continue with all the virtual resources that we've now got available.
Brilliant, thank you, Lisa. And yet again, another example of how the same concept can be applied into a different model. So that's brilliant learning and reflection. Thank you. Okay, I think I'm more or less on time. Our final contribution for this session too is from Angela Cleaver, dietitian in Cardiff and Vale, and we're going to have a look at her work now on IBS diet and FODMAPs. Okay, thanks for running that VT for us. Have we got Angela with us at the moment?
She's not with us just yet, no.
Okay, perhaps myself and Tom could just have a chat then, just a bit more about the Exemplar Bevan programme. I know that in my role as a therapies clinical quality manager, I've sort of been trying to support people within our health board in putting applications in and sharing the excellent work that the Exemplar programme can bring. What have you seen since your time at Bevan, Tom, with regards to how people are becoming engaged and how people access what there is to offer?
Yeah, is it worth me just giving a brief spiel about what the Exemplar programme is and what we provide, just so the audience can understand and give a bit of context in this time. So the Bevan Exemplars programme, as discussed previously, I think by Helen and Ruth, was designed to allow clinicians across health and care and health professionals in Wales to try out and test new ideas. So effectively, we're trying to give them initially that space and a bit of breathing space to remove themselves a bit from service delivery and creatively think outside the box about A, the challenges they face, but B, the solutions they could potentially bring and develop to overcome these. So the Exemplars programme runs for a 9 to 12 month period, and what we do is through a number of different mechanisms, we try to provide a comprehensive packet of support for exemplars into the programme. What's been really interesting, I think, in my brief time as innovation lead for the Bevan Commission is just seeing the sheer diversity of projects from a vast range of medical specialisms, and I can see everyone's arriving into this now, so I won't take up much more time, but so we're about to embark on supporting our 7th cohort this year, which starts next Thursday. But I would highly encourage everyone just to have a look at the programme and just, as we said, a recurring theme, be bold, and we can support you with those ideas and applications along with your health board leads and your organisational leads to develop this. So just give it a go, it's worth it, and we'll do all our best we can to support you.
Thanks, Tom. Thank you. I see Angela on screen. Hi, good morning. Thanks for joining us, Angela. And we've already run the VT, so we've learned a little bit about the project that you've been involved with. So I just thought, we might start with this adopt and spread. How have you found it? Any tips? Any barriers? How have you overcome those? What's it been like for you?
You're just muted, Angela.
There's usually a Teams gremlin in every symposium or online event, isn't there? Are you unable to unmute? Perhaps you might have to come out and come back in again. Okay, just a reminder while Angela tries to sort out her technology, if anybody's got any questions, so it's not just myself and Tom, we're really keen to hear from you. So get those questions typed into the Q&A chat at the side. Thanks.
Right, I'm back in.
Yay!
I couldn't even see a screen with anybody on it even. It was giving me nothing, but I'm on a laptop in Barry Hospital, so the technology, even my clinic system, I have to do Control-Alt-Delete to get out of it every single time I book somebody in. It's mad. Right, so what I was saying was we were obviously adopted during COVID, so we were supposed to be adopting a project of Debbie Thomas's, which was the staff service for IBS. But in Cardiff and Vale, we already had a staff service with a dietitian that was able to provide FODMAPs. And during COVID, we had very little uptake of that service, whereas our community service were inundated with patients and were being moved to the Dragon's Heart to
to provide a service there. So we had a discussion with Bevan about doing something slightly different. So we actually started more patient clinics and working on primary care patients, mixing them in with our secondary care patients, and doing that instead. So because of COVID, I guess using telephone, attend anywhere, and it also helped us to push through email protocols, which we'd never really got around to doing before. But it made it, I don't know whether people were more open to getting the paperwork done in terms of the data protection elements of that. But we were able to email food diaries to patients, so we had the information that we wanted. So we ended up doing something quite different to Debbie's project, but something that worked for us. But that was something that Bevan were able to support us with.
And I think that's one of the beauties of the Bevan programme, is that you can take aspects from various programmes of work and then apply them into the setting that you're working with. So that's a really good learning and reflection, Angela. Thank you. We just got one question from Versia, which is, can people actually self-refer into this directly?
So in Cardiff and Vale, that's a little bit trickier. They normally go through their GP, because we do need to ensure that they have had things like celiac disease ruled out, so that it just makes it easier if they come through their GP route. But if they're staff, then yes, they can refer directly in.
Yeah. Okay, that's helpful, and presumably we'd just have to check in each individual health board as to whether that was the case nationally. Yeah. Thank you. I mean, what would you say to others that are thinking about sort of innovations like this? Have you got any top tips or any, particular reflections that you could share with the audience?
You just have to bite the bullet and have a go, don't you? And be prepared to change what you're doing. But certainly for dietetics in IBS, there's such good evidence for a dietetic-led service. It's one of those no-brainers, really, that we can make such a difference to the patient, and seeing them in a timely manner, so getting GP referrals rather than secondary or tertiary care referrals, means people are being seen sooner in their patient journey and reducing the need for invasive and unnecessary tests. So for this particular project, definitely, if you can do it, do it.
Okay, so that's the be bold again, isn't it? And I think that's be bold in marketing ourselves as well, because I saw that this is the space we need to be in as AHPs, isn't it? We can help reduce demand on our GPs. We can prevent people sitting on waiting lists waiting to see specialists in secondary care, and some of the data that was in your presentation, 300 people engaged and 180 assessed. So what time period was that over, Angela? Because those are significant figures there.
So, well, ours was from April to January, I think. I'm not sure about Debbie's data or Jane's, but yeah, it was just clinic once a week. Just getting through people, I suppose. But when we're probably coming on to this later, but we've now started trying to do some first line group sessions to see if we can get through people a little bit quicker online, which is having some pros and cons.
Tell me more about that, because that literally I was going to come on to, well, what's next?
So we're using Teams and doing first line groups. So before COVID, we'd done FODMAP groups, but you need to screen people to see whether FODMAP's right for them and whether a group setting's right for them. And in terms of the additional admin, we weren't actually seeing people any more people in the time. So we're now doing first line groups, but we're certainly getting through the waiting list that bit quicker if we can persuade patients that that's the way to go. A lot of them want that individual touch, that what's specific to them. And I think especially with IBS and with COVID, we're seeing a lot more people with anxiety and depression, and there's a lot more evidence for mental health links in terms of gut issues. So it's making sure we address that in a sensitive way is really important. But they can also get support from their peers within that session and see that they're not alone, they're not the only person having these symptoms. I think quite often people get told that it's just IBS, and it's not just IBS. It can be incredibly debilitating, and helping them to understand that, and reassure them that it is IBS, it's nothing sinister, but yes, it can cause such horrendous symptoms, is really helpful, and the dietitian is best placed to do that in terms of explaining. We have to go right back to physiology, to normal healthy eating. I think we often overestimate people's health literacy, and we're back to what is a portion of fruit and vegetables, what does 5 a day look like, what's healthy eating, regular eating, why it matters, how your gut works, and if you can explain that and individualize it for everybody within the group, then that's what really makes the difference, and that's what we're uniquely placed to be able to do.
That's really interesting, Angela, because I think I've picked up there that that benefit of peer support, and we're getting that through many services, and developing our services in relation to what our users are telling us. That's a really valuable reflection there, isn't it? And I suppose out of adversity and out of the need to have changed the model, you've actually been able to develop a model that looks like it might be a little bit more effective and reactive.
And maybe because unfortunately there's a lack of dietitians within Wales who have experience of the low FODMAP diet in particular, but also how complex these patients can be. I think historically they tend to go into band 5 clinics, a bit like weight management used to be, say 20 years ago, oh, it's fine, a band 5 can do it, when actually we realise it's more complex than that. And we're getting referrals for people with functional gut problems from Ehlers-Danlos, from POTS, from Gilbert syndrome, and they need different handling to just being given a first line advice sheet. But if it's an online service, then there's no reason why we can't have some sort of all Wales service that patients could attend from any health boards, but where the specialist dietitian is. I don't see why we can't be looking towards that. We've got all Wales links, groups that could be looking at that instead as an alternative. If you haven't got the specialists in your area, then the patients could virtually attend.
Yeah, that's a really interesting concept. Really. Thank you. Has anybody else got any questions? Tom, has anything come out through other media?
No, that's all that's come through at the moment.
Okay.
I think Jane wanted to comment, because we've got Jane here. So Jane was one of the other adopters, and she had quite a different. They had a different approach in their health board to us. Okay,
Jane. Tell us all about yours.
Thanks for your time. So our approach was, as Angela said, it was a similar time frame in the middle of a pandemic. So a lot of staff were being sort of redeployed, and face-to-face contact had been lost, really. So we wanted to focus on, we didn't provide a service for staff, so that was the focus. We took advantage of this new technology that's been placed on us with Teams. So we started off doing a live webinar, so weekly education sessions. So we collaborated with our employee wellbeing service and used them as a kind of a way in, I guess, through our intranet pages. So we promoted the service through posters, QR codes, which would take staff. So we scattered posters around toilets and changing areas. That signposted them to the employee wellbeing page, where they could access a self-assessment to see if they were eligible for the programme. As Angela said before, we we needed to make sure we weren't misleading people. People think they've got a bit of IBS, but unfortunately symptoms of IBS can mimic other conditions that are more serious, such as cancer or inflammatory bowel disease. So we wanted to make sure people are aware that of those red flags, and we wanted to make sure we were getting the right people onto the programme as well. So we created like an algorithm where they completed a self-assessment, and if there were red flags, we did signpost them back to the GP for further investigation to rule out IBD, cancer, or celiac. And then if they were eligible, they were invited to our live education session, which was first line advice. We didn't go straight into FODMAP because more often than not, as Angela said before, the fundamentals aren't there. It is literally just first line IBS advice can provide enough benefits from re-educating, healthy eating, regular meal patterns. But we did give them advice on low FODMAP and signpost if they didn't feel that they got adequate symptom resolution. During this time, uptake wasn't great, and I think we were whittling out people too much with the whole red flag thing, because if they weren't eligible, they were just signposted to the GP, they weren't invited to the session. So we relaxed that a bit, and we didn't relax it completely, but we said, you have red flags, be mindful of this, however, please continue to join the programme. We also got contact from one of our colorectal nurse specialists who was interested in getting involved, and so we did a collaboration with the CNS and evolved the session to include sort of more functional medicine management as well for IBS, which was lovely. It was like not something, an area, it was within my remit to kind of, or knowledge or experience to give that advice. So to have the CNS involvement, and then again, uptake wasn't great. So we were looking at, how can we make it more accessible? So we ended up recording the session and making it more as an on-demand video to watch, which is available through the intranet. And we used is it with Microsoft 365, the Sway app, as a platform to host that, and it just meant as well, it took away from dietetic clinical nurse specialist time, that it was pre-recorded. It kind of was self-sufficient at that point then, and that's where we've left it really, for it to continue running on demand. We're using Microsoft Forms to collect proms and prems, so it's very much ongoing. I must add that like my role has since changed. I'm employed by Swansea Bay now. I'm in a different role, so I have handed the service over, but I believe that's how we've left it. So at the minute it's like an on-demand sort of webinar with information resources that staff can access at any time. Yeah.
Yeah, well, thank you, Jane. And I think that's, you know, it's a really good example of the continual need to evaluate and alter and change and then try again. And then, you know, and there's a lot to be said for that methodology, isn't there? And there's improving quality together. So, yeah, thank you. That was a really valuable sort of insight from how it was for your service. Thank you. Okay, so I think we're more or less on time to pull session 2 to a close. Thank you to all of our speakers in this session. Really, I've seen you being bold, I've seen you reflecting, and I've seen you adapting. So thank you very much. And again, thank you for inviting me to chair this session. I think we're just going to close with a small video message, and then I'll be handing over to Mark Knight for the chair of session 3. Thanks again. Bye-bye.
Thank you. Bye.
Good morning, everybody. Welcome to session 3. If you've been present since the start this morning, I'm sure you'll all agree there's been a really wide breadth of successful projects from across Wales, and I'm sure that will continue through this session and this afternoon. So it's very difficult to virtually applaud people so far, but I'm sure we're all doing that virtually at the moment. If you're also just joining, welcome. I'm sure that you are going to benefit from the forthcoming session that I'm chairing this morning. So my name is Mark Knight-Davis. I'm a consultant MSK physiotherapist from Aneurin Bevan, and really is my kind of pleasure to chair this session this morning on 2 very innovative projects. So I am just going to introduce the first one, and the first one is a colleague of mine, which I'm delighted to present, and it's Natalie Elliott. Natalie is our National Consultant AHP Lead for Dementia in Wales and based in Cardiff and Vale. And Natalie's project is titled Get There Together, a resource to support the people of Wales to access their communities. So we'll have the presentation first, and then I will have a discussion and questions with Natalie after. Thank you.
Good afternoon, everyone. Today I'm going to be talking to you about a national project that I've been leading called Get There Together, a resource to support the people of Wales to access their communities. I'm going to start by sharing with you a short digital story that provides an overview of the project. This was created by Jenny Evans, who's an occupational therapy student who was on placement with this project.
Get There Together is a national project aimed at people living with dementia and their families. To help them to adjust to changes in the community due to COVID restrictions. Many people living with dementia have needed to isolate or shield. Them and their families have been worried about going back into the community now the restrictions are starting to lift. People affected by dementia have felt that they've experienced a deterioration in their condition, as well as increased memory loss, problems concentrating, and increased difficulty with reading and writing. Many felt that they had lost some of their abilities to complete daily tasks such as washing and dressing. Digital stories are around 2 minutes long, and using pictures, videos, voiceovers and text can help to relay important information. They can be used to highlight changes due to COVID restrictions, such as maintaining social distance, by showing examples of signs people could expect. One-way systems, they are available for specific community locations, such as shops, cafes or restaurants, healthcare services and community groups. As the videos are aimed at people living with dementia, it's important that they are accessible to all, so they will also be available in leaflet format and English and Welsh versions too. The project hopes that by using the videos, it will help lessen anxiety, reduce isolation and encourage inclusion for those individuals living with dementia. The digital stories will be available on the Dewis Cymru website for individuals and their families to access.
There is a national project group that provides governance. Each subgroup has a lead who attends the national group and feeds back to their region. We've been supported by Digital Communities Wales, who provided us with a training package on how to create a digital story. This means that all project members are following the same process. Each subgroup has a range of partners working together on the project. This is an example from the Gwent subgroup. The project has been active for less than a year and has achieved a lot in that time. At the moment, we have 76 videos uploaded onto Dewis Cymru. We've used survey and focus group feedback processes. We've had growing interest in the project, with new regional subgroups and new partners coming on board on an ongoing basis. Get There Together was launched with a comms campaign on the 10th of May 2021, and we've had media interest. The project was featured across BBC Wales platforms. So for our next steps, we've recently started working with the Accelerate programme, and we have formed a relationship with an industry partner who's producing 5 videos for us using 360 filming. We've got ongoing work on our evaluation of the resources. We're provided with Google Analytics from the Dewis Cymru site. We've also started working with the Centre for Ageing and Dementia Research, who are going to work with us on a small pilot evaluation, which will include speaking to some end users to examine the impact of the resources. We're also thinking about how we broaden the scope of the resources we're making. And an example of that is we've recently been thinking about care home residents and how we might adapt and develop resources to support them. And we're also considering other ways that the resources could be used. An example of this is we may look to develop an app that would allow the user to personalise the videos and create an activity calendar. So I just want to say thank you so much for listening. And on this slide, you can see links to our resources on Dewis Cymru. So please do take a look and share them.
Thank you, Natalie. I think all of us would agree that kind of dementia is touching all of us, whether we're clinicians, kind of relatives, or carers. So thank you very much, you and your colleagues, for the work you're doing across Wales, really. So we have some questions. So I hope you don't mind us me asking you some questions on behalf of the panel today. And if there's any more coming in, I'll ask you those as well. So first question is asking you really, how's it going right now? And what is new since you last presented your work? Because I suspect this isn't the first time you presented it, Natalie. So over to you.
Thank you very much, Mark. That's a really helpful question. So yeah, it was a couple of months ago that we recorded that presentation, and things continue to progress and move forward. What we've started to think about differently in the work we're doing is the focus very much at the beginning was about COVID. So one of our drives was to help familiarise people with some of the COVID measures that were in place, like the video from the student was describing. But of course, that's a changing picture. We don't know if some of those measures may come back as we head towards autumn and winter, but at the moment some of those have been removed. So we update our videos accordingly. So there are some videos that we've currently working on at the moment to make sure they're up to date and have the right information. And we've made them in a way that we can do that quite simply, because they're made of still images that we can just remove the ones that are no longer up to date and easily replace them without having to re-record from scratch. But we are hearing from people that they find really helpful the videos in general as a tool to sort of familiarize themselves with locations, maybe if they're invited to an appointment for the first time. So we've had recently a new video created by our memory assessment service in Aneurin and Bevan about how to find the location of your appointment on site. Really interestingly, one of our members observed by being on site on a particular day that she was often finding people quite lost and stressed, ironically trying to find their memory service appointment. So they've produced a lovely video that describes, you know, depending on which entrance you enter the hospital from, where to go, where to park, and how to locate the correct building, and then now sending that out with all of their appointments as a link. So that, you know, is another example of how we think these resources can be used. And now that we're in a position where some things are opening back up, like community groups and support services, we're working with some of those organisations to encourage videos produced about their service as a sort of introduction to the service, or a sort of re-familiarising people with those services. So I think even past kind of, if we can look to the future and not need to worry about kind of COVID measures, I think that these types of resources are still extremely valuable to our services and the work that we do. And I think the other thing just to stress as well is that whilst we have come from the perspective of wanting to ensure the resources are accessible to people living with dementia, that good practice that we've employed in making sure they're short and the content, you know, easily accessible, means that they're good for many populations. And we've had quite a lot of interest from people who are finding difficulties with their mental health over the pandemic, from other groups like people with learning disabilities, autism as examples. So we are trying to sort of market them widely, and we're currently, because we're in World Alzheimer's Month at the moment, doing some more comms work at the minute, trying to sort of constantly be keeping the resources on people's agenda and getting them shared.
Thank you, Natalie. I think that you're right. I think sometimes we all, perhaps in healthcare, take for granted things like signposting to appointments, isn't it? You know, and I think it's great that kind of what you're doing is kind of highlighting that. So, you know, the less stress people can have attending kind of not just hospital-based service, but community-based services, the better, really. So I think you said, you know, a small example of, although a small example, a huge impact, hopefully, you know. Yeah. You started to talk about how the work you're doing could impact kind of other areas. So that kind of does lead me nicely onto kind of another question, which is asking you really, how do you think others might look to learn from what you have done? So can you expand a bit more on, you mentioned about mental health there a little bit, and others have taken up or been aware of what you're doing. Can you share with us some key points, key learning points for the rest of us?
So I think in terms of our particular resources, I think it would be fantastic to see other areas kind of joining us, I guess, and thinking about this within their services. And the beauty of the work that we've done is that actually everybody involved in the project really didn't have prior experience of creating videos, you know, and we've had really good support from Digital Communities Wales, and people have learned a new skill quite quickly. after sort of an hour's free training on how to do it, and people have used that in their work in other ways as well. So they've learned something that they can use on an ongoing basis for many different things. So I think it would be wonderful if we could see lots of services thinking about this and thinking about how accessible they are. The appointment, getting to an appointment is a great example of that, but it's much broader. So I think that would be the first thing in terms of the specifics of this project. But I think wider than that, what we've really learned from being part of this process is to take a project in stages. It can be quite overwhelming. I mean, particularly because we were looking at this from a national perspective, and people with dementia said to us at the start, please don't produce really generic videos, because my shop might not look like, the shop that you put in your video, which was a huge challenge, could be quite overwhelming to kind of think so big at the start. So I think what was really helpful for us was to kind of take things in stages and to really invest in building relationships with people. So one of the things that you saw in the presentation was how we've grown different subgroups in regions across Wales, and all the partners that have come on board, and that has taken some investment in time and sort of building those relationships and supporting each other. And what's been so lovely about the project is that national group that come together, really share ideas with each other, share resources. We have kind of a SharePoint page for the group where we can put things that have been developed by different regions, and I think that kind of support network. And that's one of the things that we are looking to evaluate as part of our work now, is how that worked in the project, and that's been kind of something that's come out of it that we didn't necessarily think as much about at the beginning, that I think those relationships have really helped with the success of what we've done, and how we can maintain those connections that we've made for other pieces of work going forward potentially as well.
Thank you, Natalie. So it seems to be some clearly transferable skills for all of us really there, isn't it, in terms of the videos and the power of those for kind of supporting citizens across Wales. And also that kind of the use of SharePoint, Microsoft Office has been a big thing for us in COVID, so we're all getting used to that, aren't we? So a bit of useful tool, definitely. So what I also like to ask, and if I can move on and say, obviously this has been a digital project. So how can others get involved and use the resources that you've come up with, Natalie?
Thank you. So all of our resources are available on the Dewis Cymru site, and after I finish talking, I'll post links to those resources in the chat. What we're encouraging people to do is to think about, if you're a practitioner, how either you might find useful to share them with people in your work. So using the resources that currently exist and making people aware of those. And then I guess the other thing is considering whether there are gaps in our current content and whether you might like to be involved in our work. We're constantly welcoming new people who are interested in developing something for their area. And so if there is anybody who's listening today who has an idea and wants some support, as I said, we've got lots of resources and experience now in the group, and we'd love to work with you. So I think those are the main things, thinking about how we share the resources, how we use them, and how we continue to grow what we've already got.
Thanks, Natalie. I think what you just said there about kind of offering for support for people and people joining in has been a message through the whole morning so far, really, in that all the presenters have been very open in wanting, or asking people to contribute if they want to do. They're available to guide. So it's great to see that across Wales, really, and your example is very similar to theirs. Can I just ask probably a couple more, if I may, then? Tom, I'll come to you in a second, see if there's been any. You talked about the partnership, Natalie. For me, that's and there's a couple of examples earlier on today about something. incredible examples of reaching out to partners across Wales. You know, how kind of easy has that been, and have the partners been, you know, readily kind of open to this, or have you had to do a little bit of arm twisting or persuasion to kind of get people on board? So how's that gone?
It's been a process. So what I would say again, it's about thinking in stages. So we started out as you know, very small numbers of people who actually using distribution lists and contacts that we had across Wales, and just reaching out and saying, is this something people are interested in? Would you like to be involved? And sort of formulating our ideas together at the very early stages. And then from that, sort of looking at where we might have gaps, I suppose, and trying to build particular relationships where we think we have them, maybe certain regions, looking at where, you know, we haven't got subgroups, and trying to engage with people. But really, I think a lot of it is about investing time in going to discuss the project in various meetings and forums, and encouraging our current members to think about what connections they have that we can grow. And as I said before, I think how different regions have learnt from each other. So examples of partners that I showed, you know, Gwent earlier, that's just one example, but some of the ideas of who that group have connected with have then inspired others. So I think you know, it's starting small and sort of building on that has been a really important part of the project.
So kind of using some of the partners, utilising some of the partners to encourage others to join and be part of it then. Yeah, great.
Yeah. And giving opportunity to people who have joined. So you know, we've got a lot of people who are working in very different organisations, and having offered the experience of coming to present, coming to talk to groups, supporting those people with you know, example presentations, and just really, I think, has been important that this is a project owned by everybody, so that people really take that kind of feeling some ownership and pride in what we're doing, I think has helped as well.
Thanks, Natalie. And can I may ask, was this project planned prior to COVID, or was it something on your work plan, you know, already in terms of, you know, one of your objectives, or was it something that kind of COVID has accelerated or brought to the fore as more of an immediate kind of need?
So it was totally inspired by what we were hearing during COVID, were issues with people living with dementia. So so I actually came into post just a few weeks before we had COVID done on us. So a lot of my initial plans had to very quickly change and be, you know, very responsive. And one of the things that we have had in Wales, which has been really valuable, is a national group of people across Wales involved in dementia care, meeting regularly and particularly quite frequently during the sort of intense stages of the pandemic early on. And that's been a really co-productive group as well, as involved people with lived experience sharing their feelings and experiences. And one of the things that they shared there was how fearful people were about going out, leaving their homes. So that's where the idea was born from, and we sort of you know, I guess it came to me as a possible thing that we could do, and then we put that to various different people with lived experience and said, do you think this would be in some way helpful? So yeah. Great.
Natalie, thank you very much. Tom, are there any outstanding questions that you can ask Natalie?
Yeah, thanks, Natalie. Again, another really interesting project. And we've had one question through the chat, and this is touching on a point I think you discussed previously. And it asks, have you had any interest from the health boards about developing a library of resources or similar resources for this issue?
So we've been working with health boards, and there are sort of some examples of resources that are specific to locations within our health board. So as I said, you know, the example of the appointment, we've got others that have been done from a couple of hospitals in Cardiff and Vale that are about the entrance to the hospital, you know, and describing kind of finding your way and the volunteers that are there to help. And then we've had kind of more specific services that have done videos, but there's so much more we could do with this, I think. So so it'd be great to see more of those kind of developing. Particularly thinking about another idea that came up was the experience of visiting, where to go and what to expect and those sorts of things. So there's a lot more we could do. As I mentioned in the video, we're looking at care homes more now as well, and we're just waiting to secure some funding to hopefully do something around that, because we've heard of some really sad stories of residents that are very fearful of even leaving their room, never mind going out of the care home. So there's lots more we could do. We'd like to do more to reach people from BAME communities, so we're looking at maybe developing a resource that has a bit more of a focus there as well. So yeah.
Great. Natalie, thank you very much indeed.
Thanks so much for all the questions.
No, great, the presentation, thank you, and your answers to the questions, fantastic. I can hear some virtual applause, by the way, so I can assure you there's lots of virtual applause. So thank you very much indeed.
With thank you. Thanks everyone.
Okay, so again, it's my pleasure now to present the to talk with the second presenter in this session, and I'm delighted to kind of introduce Emma Francis. So Emma is a highly specialist occupational therapist from Cwmtaf Morgannwg University Health Board, and the Emma's project has been the Need to Know Self-Management Communication Tool.
So firstly, my name's Emma Francis, and I'm employed as a highly specialist mental health and autism spectrum disorder occupational therapist, and I support adults with a diagnosis of ADHD and coexisting mental illness. So just to set the context, my AHP Exemplar project. So
Can I intervene for a second? I'm not hearing Emma's presentation.
We're just restarting the video for now, Mark. Sorry.
Oh, lovely. Thanks, Fern.
Sorry, bear with us just one sec. Sorry, Mark, we're just having issues with the sound on this video. I don't know if you want to have a chat with Emma in the meantime.
All right, okay.
Thank you.
Emma, apologies for this. Is there?
Can you hear me okay?
I think so. Yeah, yes, I can hear you clearly. Yeah. Would you like to give us a? While we're waiting for the technical glitch to be resolved, would you like to give us a little brief intro?
Sorry, can I just intervene a second? Emma, I think you've got a delegate view open as well, because it's echoing through your microphone. We can hear ourselves twice.
Oh, I don't, how do I change that?
Oh no, I think it's okay. I think it's stopped. There we go. Sorry, I'll leave you to it. Thank you.
Okay.
So
sorry, Mark.
Sorry, Emma. No. Like I said, apologies for this. Are you able to share with us a little bit of information about your project while we're waiting for the technical glitch to be resolved? And we can cut to the presentation as soon as it's ready then.
Okay. So the need to know document I work with in mental health services, and my patients all have a diagnosis of autism spectrum disorder, and delivering specialist intervention, it became very quickly apparent that there was much need for a communication tool which would sort of allow people to reduce their distress mainly, and allow them to attend appointments, so they were able to sort of monitor and maintain both their physical and psychological well-being. You know, there's plenty of research around with the autistic population that evidences that there's increased mental illness and a reduced life expectancy when compared to the neurotypical population. The need to know document was made initially for a crisis situation. I had a patient who was admitted to a general ward with sepsis, and the ward had contacted me because I'd been working with her, and she was in crisis at the time. And it was all due to sensory differences. And as soon as I was able to go to the ward and communicate this to the staff, you know, sort of changes were made, and, you know, it sort of made her treatment and care a lot smoother. Can you hear me okay?
Yeah. Just tell us as much as you wish to, Emma, and we're all yours.
Okay. So then the patient passport, as it was called at the time, that was presented as a quality improvement within the health board, and it was actually Angela Bell that suggested that I apply for a Bevan Exemplar.
Emma, Emma, can I interrupt you? Sorry, apologies for interrupting you.
Yeah.
The video is ready, so I think you might be relieved. You can sit back for a few minutes and listen, and then I'll come back to you then, and we'll have a good chat once the video's been shown. Is that okay?
Yeah, that's fine.
Lovely. Sit back and relax for a few minutes.
Thank you.
Thanks, Fern.
Sorry, Mark, there's still no sound for it.
Emma, I do apologise. So I think the flow is back to you, I'm afraid. I think you finished off by talking to us about the start of the introduction with the Bevan Exemplar. So are you happy to take it from there? You're on mute, by the way. Emma, you're on mute. There we go.
Can you hear me now?
Yeah, absolutely. Yes, I can. Yeah. Thank you.
Okay. So the application to Bevan was made, and it was selected as a Bevan Exemplar project. The initial, it is a paper document in its current form, and it sort of soon became apparent that there was potential to make this into a mobile app. I'm sorry, I can hear talking as well in the background.
Yes. think everybody should be on mute apart from you. There's nobody. I'll mute myself just in case. Try again, Emma. Sorry.
Okay. So yeah, it was you know, being part of the Bevan sort of commission experience as such, then it sort of provided loads of opportunity for networking during the events. And as I said, you know, some of the service users were reporting that the paper document wasn't convenient for them to carry around. So I just wanted to find a way really that people could we could transfer this onto people's mobile phones. You know, that is doable at the moment by removing sort of personal details and, you know, sort of adhering to GDPR. There is a way of transferring the information via a PDF, for example. But then to take it one step further, it was around sort of developing an app that would allow people to have access to this communication tool without the need of specialist referral. My role within CumTAF is quite unique. I've sort of given the last talk I give in the NEC in Birmingham. To my best of my knowledge, there's not another role within mental health services within the whole of Wales or England. So it's really quite unique. So that was really important to me, I suppose, is that people can sort of develop, they can self-manage their sensory differences. And with the mobile app, it would be around them making sort of selections through multiple choices, where they could select what sensory sort of strategy would suit them, and then it's developing into this need to know document. So like I said, it avoids the need for specialist referral. As part of my sort of Bevan journey, I did link up with an industry partner to discuss developing it into an app. But it sort of soon became apparent that I really wanted both the sensory strategies to be really meaningful to the person. So from that, then I decided to sort of take a step backwards almost, and I contacted our research and development department, and we decided that we would sort of register the project for an evaluation, which I done, and we sort of the title of the project was an evaluation of the communication tool designed in co-production with service users to communicate sensory differences at times when they're unable to. So what we were looking to do was the outcome measures would have been questionnaires and individual telephone interviews to form a baseline really of a research study. And that would then inform the development of the mobile application. Like I mentioned before, there were sort of benefits as well for the NHS. So the data collected would contribute to limited evidence of the use of communication tools to self-manage neurodevelopmental disorders. And furthermore, the data would be used as a baseline for the research study to inform the development of the mobile application. And like I said, it had potential then to avoid need for specialist referral, and that it aimed then to demonstrate prudent healthcare in practice.
Emma, thank you very much indeed.
Yeah, it's okay.
You said your role was unique, and if I'm honest, you've showed your uniqueness this morning by adapting to the technical glitch and taking us all through that journey. So thank you very much indeed.
I think I've had the biggest gremlin so far.
You did a wonderful job. Thank you very much. So I'll ask some questions, if I may. Is it okay if I?
Okay. Yes.
So. Again, can I just ask, just for clarification, the age group that you've looked at, am I assuming adults, or is it across the age range from young people to adults? Sorry, that's.
So, sorry, I work in adult mental health services, so it's 18 to 65. But the application, the app, and the current paper document has potential to work with children and adolescents alike.
Okay, and you mentioned really this started with one single case, then one single individual by the end of it. Wow, it's fantastic. Yeah. So you took your
worked in collaboration then, and I was able to observe the piloting of it because I supported the person to outpatient appointments, and we had the paper sort of format. Like I said, it was a patient passport then, and I could see it in practice almost. So with them giving it to the sort of the nursing staff, and then you can see how the care and treatment was adapted accordingly to meet her needs.
So this, for you then, so you took your inspiration from that person and what you were observing, what was needed in that crisis stage you mentioned.
Yeah.
So I think this is a great example of how something can start just from one case, isn't it? It's superb.
Yeah, and it's something that sort of evolved over a period of, I think, 3 years in total. Because it is part of the specialist intervention that I currently deliver. Even the title got changed from patient passport because it was found to be quite disabling in the way that the documents are widely used in work settings, in universities, in colleges. So it really has the potential to, to sort of support people right across the board. And that's where the title then was changed to Need to Know, in opposed to patient passport.
So it sounds as if there's been different versions of this then on this journey you've been on.
There's been loads of different versions. Yeah. Even down to like I said, it was the title, it was the colour used in the document. So we've done a lot of research into a suitable colour, font size. It's there has been a lot of research gone into it so far.
And how have you kind of personally coped with those evolving changes? Is that been something that you've driven or supported by, Bevan Exemplars, for example, or the kind of R&D department you mentioned? Have you had, it sounds as if you had that support through this time as well? Yeah,
it's I mean, the greatest challenge is being a lone practitioner, and I cover the whole of the health board. So the sort of, the demands of the role can be quite intense at times, and being able to sort of allow the time really to develop the document further, that's, I think, been the greatest challenge. And of course then with the impact of COVID as well. So yeah, it's just something that sort of just keeps evolving, and it's always sort of adapted based on user feedback.
So what you mentioned earlier on about your evaluation, can I ask again, just what stage is that at? Where are you at with that?
So the evaluation got approved by our research and development department, but it's sort of all the documentation was developed, so your participant information, consent, and the interview, semi-structured interview were developed. So yeah, it just needs to be sort of rolled out now and gather the data and sort of, make the changes based around the data collection.
Okay. So again, I think you're in a, you've really taken this forward, which is, like I said, fantastic, superb. What would you say to someone who wants to use this tool when they work with individuals with ASD in the community where they work? Emma, okay. What would you say to those people? How would they use it? How would you support them? How would you advise them, guide them, etc.?
So I think my involvement within the Bevan project has certainly raised the profile of the need to know document within the health board. Sorry, can you hear and see me?
Yeah, you're okay. Yeah, it went in, it lost a little bit, but you're back. You're okay. Fine.
Yeah. So what it's allowed me to do is to the demand for training around ASD awareness, has increased significantly lately, and I'm able to sort of then use that as a platform to encourage people to either ask, people with autism, do they have a patient passport, or whether they actually have a need to know document. I think from a wider perspective, what I generally find is working with people as part of the specialist intervention, the need to know document is sort of developed after I use a sensory profile assessment. So that gives me a really good understanding of the sensory deficits that are quite evident with the person. But in saying that, I think just through one-to-one conversation with users, you'd be surprised how much awareness they have about what they can and can't tolerate. So it is just about transferring that data into whatever format it may look like, and then supporting the person to take that forward, because the ultimate aim of this is having something, whether it be on paper or a mobile application, which is a communication tool that communicates the person's difficulties at times when they're unable to.
Emma, thank you very much indeed. I'll just bring Tom in to see if there's any further questions, Tom.
Yeah, indeed. And again, thanks, Emma. I know you've had a really challenging session, and we do apologise for that. But we've got one question from the audience, and I've got a couple myself, if that's okay. So the first one from the audience is, are these plans similar to those used in education for students who are not neurotypical?
Sorry, just to clarify, is it the same or could it be used?
Are these plans similar to those used in education?
I'm not quite sure, because like I said, I work with adults. I wouldn't be aware of what's actually being used in education at the moment. Like I said, it's being used in, thinking of it from a school point of view, it's being used in colleges and universities. But I'm aware that there's loads of sort of different formats around.
Okay, fab. So I guess
part of the research moving forward.
Yeah, no, exactly. And I think one of my next questions was, what sort of support do you need moving forward, and how could we best provide that support to help you to achieve what your ambitions are in the future with this?
I think from a support perspective, like I said, we need to complete the evaluation just to make sure that whatever is developed is meeting the service user need. That's the sort of primary focus there. Support moving forward would be advice around linking with an industry partner. Like I said, initially before COVID, I did have conversations around the development of the app, but it would certainly be support around the sort of IT side of it and the development of the application, and being able to apply for different funding streams as well, because funding, was an issue.
Yeah, certainly, and I think it'd be interesting to link you up with Natalie as well, one of the previous presenters who's got that industry partner now and is working with sort of the innovation support program and the wider ecosystem in Wales. So yeah, we'll make sure that happens, so you can have a chat with that. I guess my final question would be, so this is all very successful. What would your top sort of 3 tips be to people in your position 12 months ago, with an idea but not sure whether to carry it forward or how to go about it really, and how best sort of what are the 3 critical success factors that you've learned that you would pass on to others?
I guess it would be, you know, I've listened to the other presentations throughout the morning, and yeah, I mean, just go for it. It was all very daunting initially, but I think I've learned so much from the experience. Even though it's still a paper format, it's not been developed into the app. You know, like I said, the journey and the Bevan experience has just been invaluable. You know, the networking opportunities we had when, you know, prior to COVID, when we were attending the events, it has just been a really good learning experience.
Awesome.
Emma, on behalf of all of us, thank you very much for adapting to the technical situation. It was fantastic.
Thank you, Mark.
I don't think it hasn't kind of diluted at all, you know, what your presentation was on, and you kind of eloquently talked us through that. So thank you very much indeed. And as I said to Natalie just now, there's certainly a lot of virtual applause. So thank you very much, and well done. Okay, all the very best. Nice to have spoken to you. Nice to have met you and spoken to you as well. Thank you.
Thank you.
I think that's the end of my chairing session this morning and into the afternoon. Thank you very much for everybody, and thank you for Natalie and Emma for their contributions. I think we're a little bit ahead of time, 7 minutes by my clock. So Tom, I don't know if or Fern, do we just have an early break, or is there anything that needs to be shared with the delegates this morning before we break for lunch? Can I hand over to you guys?
Yeah, sure. I think we'll take an early lunch there, and I know we've got a sharing session later on in the day as the final agenda item. So if we can make the most of this lunch, and then I think we're returning at, if I'm right, 1:45 is the next session. So take time to relax, reflect, and it'd be good to see you all back at 1:45.
Well done, all of you. I have to say that was really impressive. Really good.
comes through as a mic. Hello.
Hi, Denise. Just to let you know, we're still live on YouTube.
Great.
Sorry, everyone. My name's Sharon Davies. Could you confirm, can you see me or not? Have you just got a blank screen where I am?
No, Sharon, we can't see you.
The camera's not working. Thank you very much.
Hi everybody, thank you for joining us again after your lunch. Hope you had a nice dinner. My name's Denise Jenkins. I'm Head of Podiatry in Cwmtaf Morgannwg Health Board and the AHP lead for the Bridgend locality. So I've got the pleasure this afternoon of hosting two presentations. So if we'll kick off with the first one, please, which is from Sharon Davis, evaluating the value and impact of occupational therapy in primary care. Thank you.
Good morning, I'm Sharon Davis, Service Lead for Occupational Therapy in Pembrokeshire, but also on the call are Karen Holloway, Jane Moran, Claire Raymond and Nikki Price, who are our primary care occupational therapists in Pembrokeshire. Traditionally, people have accessed occupational therapy at a point of crisis, and we believe that occupational therapy is a significant part to play in delivering a cohesive and integrated primary and community care service by focusing on prevention, proactive care and self-management. And our model involves embedding occupational therapy within general practice. Occupational therapists are the only AHP educated at a pre-registration level in physical and psychological mental health, with a long history of working within and across organisational boundaries, including housing, employment, third sector and supporting a personalised care approach. We are an AHP that's fit for primary care. We're a good fit with what's happening there. We've expertise in prevention, early intervention, self-management, empowering and enabling people to achieve maximum functional independence, health and recovery, and doing the things that matter to them. So what did we do? We plan to continue to roll out our work that had begun in South Pembrokeshire cluster. We'd had some pace setter funding with a Brave GP practice that had taken in 1 OT to test embedding, and that was followed in 2016. They saw the benefits and expenditure across South cluster in Pembrokeshire. And the more involved that GPs became with us, the more they became aware of our specific skill set. Our occupational therapists are often thought of as the gatekeepers and providers of equipment, and our colleagues in general practice began to understand our skill set around living skills, self-care, work function, anxiety and fatigue management, and it was really helping them with what they were doing with their population of patients. So we recruited extra OTs for the north of Pembrokeshire. The workshop day, on the back of involvement with Bevan, we started to speak with our research and evaluation people. With finance, we invited GPs along to give an outline of their needs and their demographic. We engaged with stakeholders and partners in health and social care. We visited the clusters themselves and engaged with GPs a bit more. And really we planned also to roll out a vocational occupational therapy involvement as well. Part of what we've done in Pembrokeshire, we were privileged to host a project with the Royal College OT and Health and Work Unit. And the project around vocational OT was designed to help people with mental health and MSK conditions to stay in employment. So we wanted to really build on that project and expand that in Pembrokeshire as well. So we were excited, we had extra staff, we had transformational funding, we had Bevan, and we were about to get started in February, but then COVID. Initially, we were disappointed and distressed because we weren't able to start the project that we wanted to and that we put a lot of hard work into already. Staff had been deployed elsewhere, but COVID actually became an opportunity, and COVID had presented challenges around needing to support people to remain at home, and we had to use a red, amber, green rating to see people who were in the red zone, but it actually became our opportunity to measure our input at admission prevention. It wasn't specifically proactive, which is where we're aiming at, proactive, preventative, but we managed to get remote access to patient care records, which had been an issue for a number of years. Now we can work from home and still contact and record what our input is. So it actually led to a place where we were able to evaluate our value and impact more than we realised we would be able to. This slide's really sort of a composite of some of the findings that we had. Again, not going into too much detail, there was a lot that we could have brought. With the primary care OT's involvement with people where the reason for referral was reduced function. We haven't got feedback from all those people, but 67% of them are reporting early improvements. Through utilising technology and remote working, it's increased our availability and offers alternative solutions to working with people. And what we found is that our capacity increasing means our response times increased. The team I've got on the call have done a great job in collecting patient stories, which are on our Bevan web page, and it shows the importance for those people of regaining their independence. There's a post-COVID story, a self-management and workplace assessment story, and what it does is demonstrate the value and impact for patients and the outcomes for patients alongside value-based healthcare. So what, I guess, is what's the difference that we're making? We're aware of social prescribing. We can engage as part of that process. Does the person need support to participate in activity? Is the environment right for them? Do they need a group activity? Is social prescribing the right path for that person just now? Again, with COVID and people's absence from working distantly, the impact of all of that and how people are going to get back to working environments. I need to go on to my next slide.
Denise, you're back live.
Sorry, I think there's the slide coming. No?
No, that was the end of the videos. The videos were taken from previous presentations.
Oh, brilliant. Okay, lovely. Thank you, Sharon. That was really informative. I got a couple of questions before we go to the ones that hopefully have come through the question and the QA session. Obviously,
good afternoon.
Good afternoon, Sharon. All right. Thank you for that. What benchmarking information was available to you initially to actually map out your initial process? Was there much around on this on OTs out there?
Benchmarking wise, there wasn't so much around primary care and occupational therapy. Apologies, my camera's not functioning for some reason. Really, we were one of the pilots, or the pilot for primary care occupational therapy, starting up in Pembrokeshire. So we didn't really have anywhere to go for benchmarking. We did a lot of the groundwork ourselves, starting back in 2015 with a pilot in a practice, and they've expanded from then. The point at which we got involved in Bevan was when we were looking at going beyond one practice, one cluster, and trying to expand across the county. So we're part of a network of occupational therapists in Wales that's evolved over the last few years, but no benchmarking to be able to go to.
Oh, right. Okay, brilliant. Well, obviously in your presentation, you mentioned that actually the COVID situation brought some opportunities for you to change perhaps the model you were going to deliver. Obviously, whilst we're still in COVID, we're getting more used to it now and things are getting different. Has it changed your approach?
Mm-hmm. Yeah, the model we'd originally built was very much about being embedded in practices and developing responsive relationships with our primary care colleagues, and having the presence that gives an opportunity for coffee conversations and on-the-spot discussions, providing that soft education around the range of skills that OTs have. In terms of COVID, practices are recovering in different ways. Practices in more rural areas don't have so much space, so social distancing means we can't go back in. Some larger practices are more accommodating now, but really through COVID we've utilised the virtual appointments that we've been able to set up. We've been able to access surgery systems for patients with remote access to patient notes. We've been able to set up a remote referral system using electronic systems more ably to share across the county the primary care input. So it's really helped us, to be honest, through a couple of sticky situations in terms of staffing through the year, being able to work remotely, have referrals remotely, being able to access systems. We use virtual consultations through Attend Anywhere. We're able to join MDT meetings remotely. It's minimising travel and expense, which I'm sure lots of people are experiencing. And really flexibility for some of the patients that we're seeing around start and end times of day as well. And many patients, I think, appreciate that we're working flexibly because of the opportunity to reduce infection, etc. But agile working sort of increased some elements of connectivity between practices and ourselves, whilst being a challenge to good time management around looking after ourselves as well. But certainly it's some of the things we would have hoped to do over a period of maybe a year, 2 years, crashed in really quickly in a period of about 4 months in terms of COVID and access to systems. So we're celebrating that really.
Yeah, brilliant. Yeah, it's nuts really, isn't it? Some things that would have taken us a long time to get through the systems and to get agreements upon. We had that urgency to do it because of COVID, and obviously a lot of that's had a positive impact on flow services going forward.
Yeah, that's been fantastic.
Brilliant. Would you suggest there's opportunity for any more MDT working now out there in primary care or within your cluster land? Now that probably the electronic records more in place, the electronic access to the services. Is this likely to progress into that type of model?
Yes, so we've been very involved in MDTs anyway. What we're seeing is our colleagues within the community network in Pembrokeshire are more involved and drawn towards setting up that service around primary care now and using remote wider MDT inputs than just the practice colleagues, practice clinicians. So working across health and social care to resolve crises sooner, and it's just been really helpful in having that swift connectivity again.
Yeah, it's brilliant. So obviously, you know, Bevan Exemplars, this sharing good practice across Wales and then actually supporting the delivery in other health boards. What would be sort of your final message for your colleagues out there if they wanted to put a similar model in place in their health boards?
I think it's very much about having conversations with primary care clinicians. It's being able to consider ourselves as being more than equipment providers for occupational therapists, for example. Clinicians in practice didn't necessarily know what we could do and would do. We need to listen to them first in terms of what their needs are demographically, what their patient need is, what are they most concerned about as a practice, and then responding to that in terms of what can we do to assist. So for practices who may not realise that we can do work around anxiety management, medication regimes, and you know, a variety of things to do with COVID at the moment as well, people returning to work. But it's listening to the practice, not necessarily imposing our bureaucracies on them. Our referral system has had to change because each practice can work completely differently. And it's then as they appreciate what we can add, then we have that joint working and flexibility to build something new. I'd say it's going in with open ears and a willingness to respond and demonstrate your value, using case studies as a way of feeding back what that value is, and being able to chart progress in terms that's meaningful to the cluster as well, whether that's where they want to see how many patients attend less often because OTs have been involved. We were measuring that before and after, whether it's about your secondary care element, wanting to know, are you impacting presentation at hospital? It's knowing to measure that. So as I said in the video. There's any number of things we could have measured, but it's knowing what to measure that's going to be meaningful for the people that you're working with. And one of the bigger challenges is having systems that don't necessarily speak to each other.
Yeah.
Primary care, secondary care, and wherever you're keeping your OT notes, and having some kind of a method for overcoming that, being prepared for those things as well.
Lovely, brilliant. Thank you, Shannon. So we've had one question come through now, and then we'll go on to the second presentation. So thank you very much. Tom, if you've got a question, please.
Yeah, Sharon, thanks for the presentation, really informative. And I guess this is more of a question for me, but I'm just interested to understand how colleagues from across primary care have received the project, and have you managed to integrate well with everyone, or is there pockets where there have been challenges for sort of cross-sectoral, cross-disciplinary integration?
I'd say the reception within primary care has been overwhelmingly positive. It's built a really good impression of what AHPs can do within primary care. I mean, the whole push is towards having us more involved sooner in patient journeys rather than waiting for them to turn up in crisis. And that for practices at the moment is such a huge issue, and will be ongoing. It's the necessary to turn upside down that whole where people are presenting in hospitals. In terms of any, I suppose, reluctance around it, it's oddly enough probably been within our own colleagues, and seeing what's the difference between what we're doing, where we're doing it, as opposed to what they're doing. So we're catching people preventatively, early intervention, and giving people tools to manage their own condition rather than waiting for them to be in a crisis and unwell to then input. So giving people the tools to manage their own health, to control their own health outcomes in their working relationships, their family relationships, doing the things that matter to them. That's meaningful, prudent healthcare to me, catching people sooner in their journey rather than waiting for it to need an urgent response. So it's ongoing work with our colleagues to understand the difference, and still our long-term aim is to pull the whole of our provision further up that presentation model, so people are able to access us without being bound by criteria necessarily as well.
Brilliant. Lovely. Thank you very much, Sharon. Thank you for your time.
Thank you.
Thank you.
And apologies about the camera. I hope people hung in there with us. Thank you.
Hope you get it sorted. Okay, so our next presentation is, thank you. Next presentation this afternoon is from Gary Howe, and it's on Physio Now, which is a digitalised solution to access for physiotherapy. So if we have the video, and then I'm sure we can have lots of questions for Gary. Thank you.
So, hi everyone, my name is Gary Howe. I'm a Senior Service Transition Manager with Connect Health. We're a large healthcare provider based up in the northeast of England, and I'm here today to talk about Physio Now, which is a digital physiotherapy solution for musculoskeletal conditions. Now I just want to talk a little bit about what Physio Now is. So it's a chatbot which allows you to complete all aspects of musculoskeletal physiotherapy assessment online. So it'll run you through the history taking part of the assessment, and then ahead of your appointment, so that all the information is gathered. So how did your problem start? How long have you had it? Those type of questions. You can self-refer using Physio Now, so you don't need to see a healthcare before using it. It's available 24/7. It's digital, so as long as you have the internet access, you can use your phone, tablet, PC, you name it, just hook on and it'll guide you through it. And available in multiple languages to include Welsh. It's clinically led, so our senior clinical leadership team developed a decision-making tree which underpins all the questions within it. So there's over 3,000 different scenarios that it can take you through. So by the end, you'll be prioritised based on your needs rather than the date that you were referred in. And by doing that, we believe that we get it right first time or GERFT. So at the end of the outcome, you'll get to see the right person at the right time for your condition. So we wanted to evaluate the impact that it would have on clinicians, and by that we wanted to prove how safe and reliable PhysioNow was. So if a patient went through PhysioNow and then went in to see a physio, did the physio agree on the other side that the outcome was correct for the patient? And we had 99.9% agreement. We also then wanted to look at its impact for patients, and patients simply loved it. We had 82% positive friends and family tests, and the word graph on the right shows you some of the anonymised feedback that we got in relation to PhysioNow, all very positive from patients. And the little bar graph on the bottom left there shows you some of the reasons for that. So it saves some people time that they could spend at work or with family by not having to attend an appointment face to face. Travel costs that are associated with that as well. And it's just generally more convenient for people when it's available all the time and you don't have to go anywhere to do it. So with a lot of technologically based solutions, you can be perceived as being discriminatory against the elderly. But what we found in our pilot was that actually more people above the age of 65 use PhysioNow compared to the 18 to 30 bracket. We also asked patients what they felt about generally being able to access it at any time of day. So 89% were quite positive. But what we found when we broke down those stats a little bit more was that 1 in 3 patients using the service actually did so outside of core hours. 1 in 5 of those actually ended up having an urgent problem. That's something that needed to be seen in a more time sensitive manner. And in that regard, it doesn't take a big leap of faith where would those patients have went to if a technology like PhysioNow wasn't available. We wanted to look then at the system benefits that it can bring. So as I mentioned, you can self-refer into PhysioNow, and in our pilot we found that close to a third of people actually got into the physio services without needing to see a GP, and that has huge benefits to the system. It can allow GPs to better utilise their time to see your more urgent conditions, your heart problems, your cancers and whatnot, and even MSK services to be seen by physios where it's better. And there's a cost saving associated with that. And then there's obviously time and environmental savings with all that as well. The box at the bottom will show you some of the time that can be saved by admin and clinical teams. And then if you put that into an efficiency saving, so if a typical service would tend to see about 20,000 referrals a year, and if we go sort of middle of the road, so a 15% self-referral rate, bearing in mind our pilot at 60%, and a 15% self-management rate, per health board you could save just over 200,000, which then if you roll that across Wales is over $1 million per annum that could be saved by implementing something like PhysioNow into the system. So huge benefits that can be achieved for everybody. So some future developments with PhysioNow, this type of technology is constantly evolving and developing, and self-management will be a big component for us. We're also, with our tech partner, on making it a more conversational artificial intelligence piece rather than just guiding people through the algorithms. So it'll react more to the input that you put into it, and making it an even more individualistic approach to guiding your rehab and your care. And what we'd really like to see is PhysioNow used in more health boards across Wales, and hopefully through type projects with adopt and spread, that might be one option that could be looked at.
Brilliant, lovely. Thank you, Gary, for that. I actually had a little bit to do with the PhysioNow project in Cwmtaf, and particularly around with the Bridgend GPs in primary care. So I'm assuming then the data you used in your presentation was the findings from the Welsh project, is that right?
It was, Denise, yeah, and hi everyone. Yeah, so as part of our pilot, we ran through just over 1,000 patients through PhysioNow in both your health board and Haldal. So yeah, any of the data that's used within this presentation or the presentation that you just seen refers to our Wales pilot. Of course, we use PhysioNow in our services because we're an English-based company nationally across England. So we've data on roughly about 30,000 contacts that would have went through PhysioNow across our services in England.
Brilliant, lovely. And what was the outcome from the pilot in Wales? You mentioned it being rolled out in other health boards.
So no, that was the hope, that would be rolled out in other health boards. Yeah, I guess we came to almost a bit of a standstill within Wales at the minute, in that we're aware that there's a national MSK review going on at the minute as to how services across all health boards are going to be delivered going forwards, or what will there be a general consensus based on that. So, and I guess as part of that will be a landscape view as to where services are going to be at, and I would suggest probably a move to more digital based services would form part of that, and giving patients more choice to access services, which I guess Physio Now ticks a couple of boxes for. As part of our pilot, we had Physio Now, I guess, basic, whereas what we can offer now is Physio Now along with the self-management component, because that's now live and it has a really exciting development within our development of Wales. So, yeah.
Brilliant. Yeah, I was really interested in that, because having used some sort of similar electronic applications like the eConsult myself, that signposting, I think, for information, and like you said, being able to access it outside of hours, I just think is amazing and brilliant. With obviously my profession is podiatry, but would you foresee within the system, with that decision-making tree, actually bringing in other professions in as well as physio, and in terms of self-management?
To an extent, I guess, as part of it. So if we take the podiatry example as being, maybe say you have an ankle sprain and it's not recovering well, or you're interacting well with your podiatry service and they might have advice around insoles for plantar fasciitis, that type of thing. Those type of literature resources could be added on to the suite of advice that patients would get as part of their self-management component. So there is potential to interact in that way. I guess the self-management component in its own right is basically a rehab program, body specific for patients. So for example, if you had low back pain, it would give you a suite of videos of exercises to manage your low back pain with progressions and regressions accordingly. And it also provides you with the chance to still interact with a physio through a chatbot system. So if you had a query, so I know if you had 4 exercises as part of your program and exercise 2 was giving you bother, you type in a message, the second exercise is causing me a little bit of pain, what should I do? And then the physio can respond direct to the patient based on that. So as much as it facilitates and empowers the patient to manage their problem at home, it also still provides them with a bit of a safety net that they can still have contact with the service. And that's a big thing for us, because we want to empower patients to self-manage their conditions. And if they're not coming into the department, well, obviously there's a benefit there from an admin and clinical resource perspective, because as I'm sure it's no different in Wales, physiotherapists are hard to recruit at the minute nationally with FCPs. So this can have a bit of an impact on helping that burden.
Fab. So if what advice would you give any professionals if they wanted to bring this into their service? Is this something available that even private practitioners could tap into across Wales?
It is, yeah, and I guess reaching out to us would be a good starting point, and it depends on what your sort of referral activity numbers are based at, because the more volume that goes through it, it can decrease the cost of it, so there's an impact that way. And I guess it's going back to that earlier point of looking at the landscape within healthcare, and it is probably moving more along the digital route, so having this opportunity at the front end of your pathway to stratify your patients based on their needs is a very useful thing to have. And also from a patient perspective, giving them the opportunity to access services 24/7 is a real bonus for those. And we find during our pilot and across our services that the patients really like interacting with the system. They find it quite easy to use, and the stats from our pilot sort of back that up as well. And we spent a lot of it's probably taken us about 2 years to get to the point where we are at the minute with Physio Now. There's a lot of clinical input required to develop the decision-making tree that sort of underpins all those questions that guides you through to the outcomes. So a lot of manpower invested by us to try and get it to the stage where it's at now. But we feel that we've got a really clinically safe, validated, reliable and effective tool at the minute for our pathways.
Brilliant. How has it been, perhaps in England and in the pilot sites in Wales then, in terms of the primary care agenda? How has it been accepted? Because obviously in Wales there's a big drive to put first contact practitioners into primary care as well. How would you see them interfacing, or have you got an experience of how they interface together, Gary?
So I guess our work in Wales now is in the past, really. So our interaction with primary care in Wales isn't a live link at the minute, but obviously we still use it across our services in England, where all FCP have an FCP component to it, and to us it's at the front end of the pathway, which in an ideal world you would probably put patients through Physio Now rather than going to an FCP first, and then if it was decided that yes, it needed a more interaction with an FCP, well then it can go down that route, but because there's sort of CATS element as an outcome within Physio Now, so that could be directed more towards your FCPs. So it actually would mean then that the people who are going to see FCPs or indeed into your normal physiotherapy service are going to the right place and not wasting a resource, and then you're maximising the impact that your clinicians on the ground are then going to have, so that they're getting to see the people that they should be seeing and best utilising the appointments within the system.
Brilliant. Yeah, that's what I was envisaging, it becoming right at the front of the pathway. Yeah. Brilliant. Thank you, Gary. Right, we've got a question that's come through Q&A, so over to Tom.
Yeah, thanks for that, Gary. Some really interesting findings there. We've actually got 3 questions from the audience in this sense. So the first would be, how many people did not go on to require rehab from accessing the app, or is this just a way to access usual services?
You'll have to help me with that one again, Tom. Does that mean people who failed to complete or actually ended up having a Physio Now assessment and then went into the service?
So it's how many people did not go on to requiring rehab, I'm guessing from secondary care services,
yeah,
from accessing the app, or is it just a way to access the usual services?
So within our pilot, because there wasn't a self-management component at that time, everybody ended up having a Physio Now assessment after it. But what we found now for our services where we've introduced the self-management component, that we're getting on average about a 20% self-referral or self-management rate out of everybody who accesses Physio Now, i.e. then that 80% would end up going into physiotherapy departments, or at least having a further appointment with a physiotherapist. So about a 20% self-management rate.
Really interesting. So our next question is regarding future developments. I'm wondering whether there's been any progression of thinking or discussion regarding how this interfaces with the developing All Wales Urgent Primary Care model.
Again, probably I'm not best placed to answer that. The representatives from ComTAF, Zoe Brewster, who we work with, and John Davies in Haldal, are aware of Physio Now, and I guess would have taken it to those All Wales agenda type meetings, and we've also had some discussions with representatives from Swansea Bay who are aware of the work that we do as well. But if there's a way of us trying to get a seat at the table, for want of a better word, or to give a bit of a demo regarding Physio Now and how it could impact the service, we'd be more than welcome to avail of that opportunity.
Yeah, really interesting. I think there are a number of opportunities from the findings you presented, and it'd be interesting to see how we can get the people around the table in this instance to discuss that. So the final question I've received is there a link to patient admin systems within the GP practices or in CTM or however that saves time within the admin processes and so that clinical information can be transported directly into the clinical records? So it's the interface between IT systems, I guess, is the question.
Yeah, so I'll answer that in two different ways. So within our pilot in Wales, what we did was for each GP practice, put a link for PhysioNow onto their website so patients could self-refer direct using the link. What we didn't have time within the pilot, because it was supposed to be a 6 to 8 week pilot, but actually went on for 3 months, was to build a link between the outcome of PhysioNow, so the PDF that it generates, and then a link back into the clinical record system within Wales. But we do that in our systems in England, because we've had more time to develop it. But because we knew in the pilot that we were only going to send 1,000 patients through it, it wasn't deemed a worthwhile use of time or resource to try and build an API, which is the tech version of how the two systems talk to each other. But across our services in England, we do have that. So patients who can go to their local GP website link, access PhysioNow, they'll self-refer, self-register on the system, and then their outcome is then embedded within their clinical records for the physio to pick up and sort of read and see what the outcome was.
Really good. So looking, I guess, to the future, if this was to be adopted more widely in Wales, that would be something that could be developed in a Welsh context, I'm guessing.
Yeah, I think it's essential to do that because you have to have systems that are going to talk to each other, and it's not beyond the realm of possibility. In fact, we were speaking with NWIS during the pilot to discuss doing it, but like I said, the time constraints just meant that it wasn't possible during that pilot. But both their tech guys and our tech guys who speak a different language, so I'm not going to try and get into that, but they basically agreed that it's possible to do, but just needed a little bit more time.
Fab. And I've just got one question personally. You said this app was co-produced with clinicians in mind and all their opinions to get the sort of clinical rigor behind it. I'm guessing the answer to this is yes, but did you work alongside patients as well throughout to get the usability and their views on what the app and functionality should look like? Yeah,
we did, and we found that very important too. We've got a head of patient engagement who helped us with that piece of work, and what we found, especially with the number spine cases, because they can generate a lot of red flag questions, was that we had to be quite sensitive to patient wording and understanding within that aspect rather than a clinical component, because during our test phase, with a clinician only writing the question, we find that when during the test environment, patients who answered those questions ended up picking up more red flags because the question wasn't worded in a way that they understood, so they ended up just clicking yes from a safety perspective. But when we work with patients to reword the questions, we sort of got a consensus or a method of questions that works better for everybody.
Brilliant, lovely. Thank you, Gary. I'm really keen to see this, spread out across Wales and actually to include all the other professions as well, because I think if we are going to streamline and have single point of access to therapy services, this type of thing and that clinical tree sitting be within the system, I think is really a brilliant way to go forward with that. So thank you very much for attending today, and let's look forward to it being spread out across Wales. Brilliant, lovely. Yeah. Thank you very much.
Thanks.
Thank you. Bye-bye. So I think that's the end of session 4 now. So I hope you enjoy session 5.
Hi everyone, the next session will be starting at 2:45. So if you want to grab her or have a little one during this little interval, back at 2:45. Thanks.
Hi everyone, the next session, session 5 of today's event, will start at 2:45. So if you want to grab a cup of coffee or tea, feel free to. Okay.
Good afternoon, everyone. I'm really pleased to be chairing this session this afternoon, and thank you so much for joining us. We have 3 really exciting sounding projects to share with you. My name is Vanessa Hayward. I'm Head of Speech and Language Therapy in Cwmtaf Morgannwg and also an AHP lead for one of our locality groups. And I'm also the Vice Chair of the Welsh AHP Committee. So thank you for joining us this afternoon. We're going to watch the video and then have an opportunity to have some questions and answers with the presenters. And the first session that we've got is with Sarah James, who's a clinical specialist physiotherapist in Aneurin and Bevan University Health Board. And her project is around physiotherapy diaries using co-production to aid post-COVID-19 outpatient service design, which sounds a very exciting project. So can we see the first video, please?
So my name's Sarah James and I'm a clinical specialist physiotherapist at Aneurin and Bevan University Health Board, and I want to talk to you today about the innovative project that we've been running during COVID-19, which is named in short the Physio Diaries. And just to elaborate a little bit more, it is actually a project whereby we've used co-production to aid post-COVID-19 outpatient service design. So our main aim then is to explore experiences of patients whom have received and physiotherapists whom have delivered MSK outpatient physiotherapy during COVID-19 and how this has shaped their views for future service. And the rationale underpinning this is to use lived experience to gain insight and learn the vital lessons needed to be learned from this pandemic, to actively involve stakeholders in system change and to co-produce a valuable and meaningful future physiotherapy service. So how? So qualitative. So exploring lived experience is best done in a qualitative way, and qualitative research is well known for its utility in producing quality-rich information, and it allows us to explore the what, but not just the what, but the how. And then in terms of communicating to policyholder, there is analysis called framework analysis that is able to grasp that's going on the ground and then analyse that to provide a contextual explanation and then present that in a systematic way, and it's really sort of favoured by social policy research, but also healthcare research increasingly, and there is already a theoretical model for COVID-19 and creating meaningful change by the Royal Society of Art. So that was when we went out to explore physiotherapy staff experiences, and it was very, very open, and we just explored sort of how they were doing and their thoughts moving forwards. We put that into a framework analysis and we reported upon it, and the outcome was a bespoke set of recommendations for the future of physiotherapy, driven by staff reflections essentially. We also, for the second part of the work, added in patients as additional stakeholders because obviously they're really focal to the service. So we did this via semi-structured interviews with improved utility as a result of spreading and scaling this research and this work, and the improvement in basically my ability to be able to do interviews. They were captured by a video, and this was threefold. For infection control reasons, digital innovation, so ways of sort of delivering messages via video. It's been a really good way of engaging people, and it was also inspired by Swansea Bay's digital patient stories work, whereby lessons have been learned by just listening to people and recording them, and then they've been delivered in that way. We found we were able to map the results onto 3 different frameworks, the last one being the most important, but I'm just going to quickly run through the physiotherapist insight. So physiotherapists wanted to end the belief that telehealth is equivalent to usual care. They wanted to amplify good practices that they've observed both within physiotherapy and within the wider sort of world, and they want to restart full service provision. Patients, quite similarly in some ways, they want to end at current limited service and COVID-19 restrictions. They would like a hybrid model, so they're not saying that they don't want telehealth, and they're not saying that they only want telehealth, but they actually would like to be able to pick and choose as and when they feel fit. So we were able to sort of combine both of those and then put them on top of each other and be able to provide a collective insight about how outpatient physiotherapy and musculoskeletal services should look in the future. And so we shouldn't Although we brought in telehealth as an only option during COVID-19, we shouldn't use that as an only option moving forward. That should stop. Instead, we should have a hybrid model where a patient is given choice, aided by a clinician that listens, using resources to facilitate that interaction, and that could include telehealth. They want improved access to physiotherapy to include the timeliness of that response. They want to let go of the long waits, which complements the aforementioned, and they want to break the barriers of traditional care to include just treatments, but also some of the treatment choices that we have chosen. And they also want to start full service provision. Key outcomes, so I've just done a full circle. So we've managed to explore experiences of patients and physiotherapists who have received and delivered respectively MSK outpatient physiotherapy during COVID-19, and we've worked at how this has shaped their views for future service. We have used lived experience to learn the lessons. We've actively involved our stakeholders, and we've co-produced a valuable and meaningful future physiotherapy service. Barriers for this work. It's a fast evolving pandemic with many phases, and this work only represents this part of this pandemic, and you may well get different data based upon the phase of the pandemic, and that was highlighted by the first piece of work when reflections weren't becoming action points, and part of that might be to do with reflection on action, reflection in action, experience of reflective practice, but it also might be because people are not thinking about it and they're just working and they're just doing it. Well, they should be on the ground because they're very resilient and focused. However, the methodology does support quick data collection and collateral analysis, so this could just be done at those phases, and we've shown that and how that can happen. Buy-in. So I do feel uncomfortable up against sort of big projects with lots of cost savings and big validated outcome measures. It's not a type of work. But what I hope that we've managed to show and demonstrate through this is that we've managed to sort of challenge the unease of conducting qualitative work within healthcare. It is a really wide known acceptance that we don't do it enough despite its utility. So hopefully that is something that will counteract that. And I thought about not putting this in, but I thought I have the opportunity to have a platform. I worry that we will revert. I worry about reverting back to old practice. So what now? So this is just a sort of a spider diagram of how this has snowballed from a very small idea, and the small idea being, let's just go and find out how the physios are doing. I'm going to present the themes to our executive team. I hope that they informs the decision making, and I'm just hoping that the use of these platforms is going to gauge interest for other sort of directorates and other professions to use this sort of methodology to find out what's been going on during COVID-19 and how we can learn from it, both within physiotherapy, within allied health professional networks, and then wider in Iron Bevan University Health Board, and even wider again if it goes that far. We will see.
Okay, thank you very much. I think that's the end of the video. So Sarah, I can see you there. Thank you for joining us. So please do put any questions that you have in the question and answer, and we'll keep an eye on those to see if any come in. I'm just going to check to see if any are there now. If not, I shall come in with a question. Okay, I'm going to come in with a question, Sarah. So really interesting project, and especially to be able to do that during a pandemic, which is a challenge in itself, isn't it? So a great opportunity to get that patient engagement with your service delivery. I have a few questions really. You talked about a framework analysis and the Royal Society of Arts, and I wondered how did you come across that methodology to support you with this project?
Hi, can you hear me? Yeah,
I can hear you fine.
So I was both lucky enough and opportunistic enough that I was able to. At the time I was in. Go into the University of Birmingham doing masters, and I had a dissertation tutor that I presented this idea to at the end of the first stage, which was when we only involved physiotherapists and it was more iterative and we developed the first themes. So I presented my thematic analysis to him at that point just to see if the project had any sort of legs, and he was really excited about it and said actually there's a better way of analysing this to be able to draw conclusions. And basically he was actively interested in COVID at that time as a researcher. So I basically met him as a clinician working on the ground, doing sort of research on the ground with his theoretical knowledge of framework analysis. And the Royal Society of Arts, I think, are sat outside of healthcare. They kind of involved in sort of system change really, and so they had already devised a theoretical model that looked that talked about meaningful change post-COVID, and what would end, what should amplify, what should restart, and what we should let go of. And that's kind of the themes that we already had, but just in a less organised manner. So we were able to just sort of map that on top of the other, but then with additional themes of reflection. And so yeah, the initial awareness came from Ben, my dissertation tutor, but off the back of the information that we had, but just in a less organised manner. It's just quite lucky really that basically research met clinical practice in this scenario.
Yeah, a massive benefit, isn't it, of doing a master's program as well, and the added benefits you get of that. So that's really helpful learning for people as well. If other clinicians wanted to do this sort of project, do you think are there particular skills you think that they need to be able to do something like this?
Yes, I think there are a couple of skills that perhaps are not documented. So there are skills that are documented within the research about how to conduct qualitative research. So one of the sort of things that affect rigor then, so if you so academically, if you want it to go to publication, one of the things that affect the rigor of your methodology is whether you've had experience or formal training in interviewing, which I hadn't, and I can certainly say that experience improved my ability to interview people well. However, I think in this context, again back to the sort of science meets practice, I think it paid to have an insight of sort of what you're exploring. So in this example, I was working on the ground during COVID, so it not only, me being the interviewer, not only provided a sense of familiarity to my participants, but it also allowed me to explore themes to greater depth. You could argue that it created a bias, however, the further rigour of the work, so things like allowing participants to review the transcripts and peer reviewing throughout, would counteract that a little bit. But I think that's a skill that you would probably read about, that you could argue about all day, I suppose. But then the ones that are sort of, I found in my experience that are probably not documented would be first of all, the ability to identify the need to explore something on the ground, because you can quite easily do something like this about anything with no aim and no sort of way forward, but you'd end up with a really large heterogeneous data set, and that's where the trouble starts, I think, and that's where you can't use things like framework analysis, is when you've got lots and lots of information about lots of different things. So I think one of the skills is to be able to identify what needs to be explored in this way, and then also to just be able to set back and go back to your aims at regular intervals, so just the ability to reflect really. And I think that the main thing for me is, because bits of that got sort of cut out when I was watching that back, there were bits that got cut out that I just wanted to sort of draw upon now. So the main thing for me, apart from that, is to have the confidence to back something like this, because you know, we talk about things like cost savings in the NHS and how to create cost savings and how we're going to see that NHS lots of money, and I can't sit here and say that per se. However, what I can do is demonstrate the power of voice, listening to your staff, your patients, your stakeholders, involving them in decision making, giving them a platform to speak up to. They've had really good ideas that can either affirm that we're already on the right lines or actually giving us food for thought. And not only has it given us that invaluable insight, it's also provided an intended intervention and the opportunity for our stakeholders, patients and physiotherapists, to offload at a very uncertain time. And so it's identifying those sort of less obvious benefits of doing something like this, and then having the confidence to put that up against the really obvious benefits that other sort of maybe quantitative or cost saving exercises have. And so it's just having the confidence really that it is prudent, but it's just in a slightly different way. And so that's one of the things that I sort of reflected upon.
Yeah, no, and I think you're absolutely right, Sarah, in terms of our services being patient-centred. This is a great example of that, isn't it? That you're driving forward the service in a patient-centred way, and presumably keeping staff on side and being motivated because they've been involved and can see that they've been listened to about, you know, what service they're delivering. So I think that's fantastic. And also the benefits of being AHP clinical researchers as well. Like you say, you're on the ground, you're seeing these patients, but you're also carrying out some research as part of your role, which is it's something I think we'd all want to encourage as well. So that's fantastic. Did you have any challenges of engaging patients with the project at all, or were they all quite happy to sort of get involved?
No, they were actually really happy. And I tell you, the other really good benefit about actually doing it in this time is that we had the virtual platform. So took a little bit, that was one of the things, that was one of the, so the first part of the framework, we were in a phase where we could be face to face, and it was only with the physiotherapist. So we were in the working environment, so we could video them face to face, and there was an impact in terms of infection control. The second, but we wanted to continue this and not have infection control impact on us, and there were like further ethical considerations with patients as well. So the second phase we had to think about it a little bit more laterally, but the fact that we were already using things like Teams and Tend Anywhere and things like that meant that they were, number one, they were more readily able to do it, but number two, they were like really happy with doing it, and it provided really good content. So like I've produced a lot of videos since doing this to just illustrate what we found, but it's provided a really good way of sort of illustrating. But they've been really happy. What really shocked me was they were really not only happy to be involved, they really really keen to share their ideas. And not just from, so my sort of assumption was going to be that we're going to talk about physio during the COVID-19, and my second assumption was going to be it was going to be a negative view because it was virtual and difficult to sort of get to just because of the nature of the pandemic. But they actually talked about physio before, so there was, I remember one patient talked about physio in a different country and how their stances were different to perhaps us NHS physios, and it sort of brought to light assumptions about physiotherapy that I didn't even know existed. So it was really eye-opening to sort of see how they perceive, but also how much they take in just one interaction. So yeah, they were absolutely awesome. I'd implore anybody trying to redesign the service to speak to the patients, because they were really very valuable, probably in some ways sort of more valuable than some of the physios as well, who were all sort of in a consensus a lot of the time.
Yes, I think you're right. You can't always predict how people are going to respond, do you? And they're going to come up with things that you never even considered, perhaps. So yeah, absolutely, really helpful. I know you said in your video that you were going to present to the exec team. Has that happened? I just wondered how they responded to that qualitative approach.
So this is another barrier that since I think Gary in the last session touched upon this, Gary Howe. I work in outpatients, and in the last couple of months things have just absolutely like exploded. So we've got rising pressure of COVID again, and we've got patients, they don't want to stop the service, which is absolutely right, but as a result of that, like our work, I feel busier than ever on the ground, I must say. And so I was due to present in the new year, and it got cancelled because of COVID. So what I did instead was I submitted my dissertation, and that got reviewed recently. So I'm just instead now I'm putting this forward for sort of publication, so I'm going to send them that written summary when I finished it, because I've just had my results back, and do it that way. Just I think this is the only thing, I think it got cut off, which in the video, which is fine, but that's the only thing I'll say is that it's much more difficult at this moment in time to not feel guilty about doing this type of work, but I'm really aware that actually you shouldn't feel guilty, whilst it's a really uncomfortable conversation to have, and I feel really guilty about sort of saying to my boss, you know, I really want to keep going at the expense of some of my patient appointments, for example. Actually, this is what's going to provide a more efficient and more satisfied service by all of our stakeholders, and so this is where I don't want to get lost, is the fact that the value of this in a fast-running outpatient service, really, I think. So I haven't, so in answer to your question, I haven't presented the exec team yet, but it's somehow gone sort of far and wide in other sort of domains. So I go to Physio UK at the end of the month with the first part of this work, which was the stage 1, which was a bit before this. So I'm going to present to, like, obviously the physios of the UK, and so I managed to sort of get momentum in other ways. So they are listening, and they are actively sort of keen. It's just wasn't in the channels that I thought it was going to be initially.
Yeah, no, that's fantastic. Well done with all of that. And I think, as you've picked up a really important point there, that quality improvement is key, isn't it? And even though we're still in a pandemic, but we still want to improve services, and the only way to do that is to do qualitative any kind of quality improvement project, really, isn't it? Like this is the only way we're going to move services forward and improve on them. So it is really, really important to have that running alongside our clinical work. So don't feel guilty about it. It's great. It's great to have you.
I'm actually really lucky to have like supportive clinical leaders. So like I've got people that back me actually in work. Even when I don't back myself, when I imposter syndrome day, then I am really lucky to have a good team around me. I'm sure it'll be fine, and I'm hoping that I've inspired other people to go on and do this type of work in the directorate. I think I have already, just judging by emails that I've had. So I think that even if it was just that one outcome, it would be fantastic. But actually, it's gone much further than that, and it seems to be having more of like a national sort of representation now, which is really good because it's such a simple idea. It's so easily executed.
Yeah, and that's a brilliant learning for people. And yeah, I'm sure you have inspired people today, and that's exactly what this event is about, to see how other people can take on this kind of project and do something similar in their area and learn from it. So that's absolutely fantastic. Thank you very much for being with us today. So I really appreciate your time and for sharing that really exciting project with us. Thank you. I don't think there's been any other questions, Tom, has there? Or did you want to ask Sarah one?
No other questions, but yeah, I've got one question which would be great, so if you've got time. Firstly, thanks for your presentation. It was inspiring, and your passion, as always, runs through everyone, I think, and everyone. So my question would be, I picked up in your presentation, you said you were worried that services would start to revert back to traditional means before the pandemic. The question would be, have you managed to apply any of your learnings to your personal practice or to your wider professional practice? And are we starting to revert back to old traditional practices, or are we maintaining sustaining the improvements that we've made?
Oh, such a good question. Yeah, I think there is a comfort in reverting. When, especially now things are kicking off again, I think we were really brave before to say, actually, no, we've got the opportunity to get back to better, as one of my clinical consultants would say, which I think is a really good term. I think when you're up against hundreds and hundreds of sort of urgent patients and a massive demand for physiotherapy, where that's I can talk about because that's where I work in. I think it's so much easier to just say, actually, go back, fill all your slots, go back to seeing all your patients 80% of the time, which is what I'm templated for. And it's just the easier way in, and it will deal with the problem in hand. However, I think insight has given us experience has given us the insight to appreciate that isn't sustainable, and we weren't we weren't sustainable before now, and now it's going to be even harder to do. So I think what this project has taught me, as well as just the opportunity to sit and pause and think during the pandemic, is that actually, as much as it's really uncomfortable to speak up, and you might result in sort of difficult sort of conversations or interactions I previously wouldn't be comfortable with at all. Actually, you won't get anywhere without speaking up, and that's what I've learned from my participants alone. So daily I evaluate how locally and on a wider scale how we can not revert back, why we're reverting back, what's the benefit of reverting back versus the discomfort of sort of struggling for a bit to then get a better outcome at the end. And I think that's the thing, is projection. So that's one of the things that came from here, was people weren't only reflecting, but they were projecting and saying, actually, when we come back to a normal life, we shouldn't be doing this. This doesn't need to come back. Like, we shouldn't just be doing telehealth and because there's an agenda to do that, because we paid a lot of money for a platform. Actually, we need a hybrid model where patients can be seen and patients can be listened to, and they can be given the choice. And actually, should they want to use technology, that's fine, but they should be given the choice either way. I think that's the more difficult option to choose, for example, but it results in better outcomes. So, and that's kind of that's the bit that we don't want to lose, is the outcomes part. So yeah, sorry, I've gone off tangent now, but daily I'm asking questions in terms of departmental logistics and patient care. You know, why are we going back to this? What's the benefit of it? And it's usually probably because it's easier, and it's, you know, it's familiar. But actually, then you know, I think the two sort of take-home messages I've sort of taken from other people around me and myself during this time is, you know, it's that I don't know, enduring that period of discomfort to get to a better result is really sort of beneficial, but also just because it's always been done that way doesn't mean it has to continue to be done that way, because that's another answer I get a lot of the time is, you know, that's just, it is what it is and that's just the way it is. But why can't we, like, why do we have to stick to tradition? And I think that's the two things that I keep referring back to. I hope I'm not being too outspoken in my practice, but it's for the greater good.
Yeah. Thank you, Sarah. Yeah, I think you're absolutely right. Outcomes driven, isn't it? And asking ourselves that why question all the time. Why are we doing it this way? It's really, really powerful. Thank you very much. Thanks for your time. That's really, really interesting project and the discussion. Thank you. So we're going to move on to the second project. So this is using AI-enabled virtual assistants, and this is Phoebe Borry, undergraduate placement student supporting paediatric psychology service in an Iron Bevan University Health Board. Welcome, Phoebe, and we're going to see your video now. Okay, that's a great video. Hi, Phoebe. Thanks for joining us. So please feel free to put any questions in the question and answer, and we'll pick those up. But I'll start off if that's okay. One question I had, so you refer to children undertaking procedures in the video. Is that sort of health related procedures that they're needing to attend? Is just for my understanding?
Yes, it is. So the current tool that we've developed is a proof of concept tool, and at the moment it's centered around needle procedures, so blood tests and injections.
Right. Yeah, that makes sense. Thank you. So the project's been completed now, hasn't it? Yeah. So do you have any sort of further results since you shared the video?
Yes, we do. So the tool was developed collaboratively with MDT colleagues, children and families, and was given to a sample of children aged between 4 and 13 years old and their parents who were patients of an Iron Bevan or lived within the health board's catchment area. The majority of testing that we did was conducted in person, either on paediatric inpatient wards, medical outpatient clinics, and also in primary schools. with the assistance of assistant psychologists who were then able to provide instructions and help with how to use the tool if needed. We handed out posters and information sheets to families to allow them to complete it in their own time. And some testing and feedback was gathered following medical clinics, so in hospitals. And the tool was also sent then to professionals and clinicians in the health board via email within the Gwent Children's Diabetes team, the Children and Families Therapies team, and paediatric medical professionals. Children, families and clinicians then received feedback forms following their time testing the tool. We have found that parent feedback has been slightly more challenging for us to get. And we believe this is possibly due to issues that we've had with COVID and just kind of accessing parents. I suppose for us, accessing clinicians is quite easy because we're surrounded by them every day. And children, we could enter schools and meet them after clinics. But for us, having service user representation and feedback was absolutely vital to the project, because ultimately the tool is for the children, so we need to know how they feel about it and if they think it's going to be useful. So we were able to gain both qualitative and quantitative feedback from clinicians, children and young people and families via questionnaires that we developed ourselves and distributed via Microsoft Forms. And overall, the feedback was really positive. So the majority of clinicians reported that they would recommend the tool to children, young people and families, and that it would make it easier to support them in having blood tests and injections. The majority of children and parents also reported that the tool was easy to use and it would be useful if they continued to use it in the future. But for us as well, the qualitative feedback was really important, just really understanding the rich feedback and opinions. So in our qualitative feedback, clinicians, parents and children all reported that increasing the accessibility of the tool was important, such as having voice activation and more videos, etc. So at the moment, we do have some issues with the technology that we've been able to procure. So it is kind of just a bit of a chat bot. So you type in answers and the answers come back and you'd have to read them yourselves. But we are really keen to try and get this voice activation so you can speak to the tool and then the tool can speak back to you. But that's something that we'll have to pursue in the future when technology and funding allows. But yeah, so our results have been really good and really positive.
Oh, that's fantastic. You're talking about technology there. Are there any tips that you would give to other people who are thinking about doing a sort of innovation that was technology based like this?
Okay, yeah, so I can only really speak to this in terms of the clinical side rather than an innovation viewpoint. But I would say that it is such an incredibly exciting and interesting venture. It has been a long journey. We've had delays due to COVID, which couldn't be helped, but there is so much that's got to go into the development, so you would need to dedicate quite a bit of time to it. And while it may seem tedious at times, it is definitely worth it. It's been such an incredibly exciting project to be a part of. And I think for me, the best moments were when we had the first version and we actually saw it working, and then we were able to build on that and saw children using it and got the really positive feedback. But I would definitely say it's absolutely worth it. So if anyone's even thinking about it, I would recommend looking into it and pursuing it because it is really interesting.
Okay, thank you. And what would your sort of first step be in that? Where would you suggest people went if they had an idea?
Well, for us, we used the innovation team within Anira and Bevan, and we approached them. So I would say kind of that would be one of the first steps, and just kind of developing a bit of a business case for it. I would say that would be kind of the first steps.
Yeah, brilliant. Okay, and I'm guessing you can see some potential for this being used in other services around Wales. Have you, are there sort of any ideas you'd have about where else you could see it being used?
Yeah, definitely. So the next stage for us really is the dissemination process. So getting it out there, making sure people are using it, and then following that, testing it. So testing our current version and evaluating its effectiveness in relieving pre-procedural anxiety. But the potential for the project is huge, really. We're hoping that in the future we'd be able to expand it to other areas of health where these procedural anxieties lie, such as other procedures like operations, MRIs and X-rays, because procedural anxiety it's so normal for anyone, but particularly children and young people undergoing these medical and surgical procedures. And as a result of that, they may not be able to access the medical care, which can result in an impact on their physical and psychological well-being. And we know that it is so important for health services for several reasons that we combat this. Because we know children who have high procedural anxiety require increased levels of support through their procedures from their clinical team, so additional members of staff present or kind of anaesthetics, and then also the levels of distress that children and young people can experience can then lead to delays or even in them not having the procedures. And then this can then go on to develop a kind of chronic anxiety around medical interventions, which is usually managed, unfortunately, by avoidance. And this can then continue into adulthood, where they're less likely to engage in healthcare programs, which results in an increased cost within the wider systems. So we are really hopeful that this tool has the potential to lower rates of procedural anxiety and will benefit not only the physical and psychological well-being of the children and young people in our services and even across Wales, but will also lessen pressures on medical staff, reduce the amount of additional support that children require, such as anaesthetics, and ultimately result in a decreased cost within the wider system. So it has a massive potential for individuals themselves and whole services.
Yeah, no, I was thinking that you answered that really well, because I was thinking what is the alternative for children and families if they don't have access to this sort of technology, really, then, and you've outlined that really well. And yeah, and I'm sure, you know, a happy child is a happy parent as well, isn't it? So that you know, the impact on them as well, it's reciprocal, isn't it? So that's really, really important. Tom, I'm not sure if there's any questions come in before you wanted to ask one for Phoebe.
Yeah, there are. I've got a good question for Phoebe, I think. Phoebe, thanks ever so much for the presentation. Again, a really interesting presentation and a great project. So what I've got written down from your presentation was true co-projection to support self-management in a truly patient-centric manner, which I think ticks so many boxes of everything we're looking for at the moment. So I guess my question would be, what are your personal reflections about how we can best access and utilise the experience of population segments that are hard to reach effectively? So drawing on your experience of looking at parents and accessing children with these experiences, how can we best access and utilise their sort of lived experience to improve services in the future?
Okay, so for us, I suppose we did have the benefit of kind of increased use of technology during the pandemic. So we were able to reach people via Teams for focus groups and things like that and gain opinions that way, and understand kind of their lived experiences. But it is, we agree, like it is so important to understand kind of lived experiences and have that feedback flowing through your service. But yeah, so I think that's it really, sorry. Yeah, definitely. I think for us, kind of the pandemic has had its benefits in terms of making things more accessible to people, in terms of kind of using online means. I know for us as a service, we kind of tend to have one base, and our health board is so wide, so it has been really good to kind of access people that way and gain feedback.
Perfect, thank you.
No problem.
Fantastic. I know other chairs have talked about virtual applause. I'm sure there's lots of virtual applause going on for our presentations in this session, and for answering all these questions that we're throwing at you. So really appreciate that. Thank you very much, Phoebe, and thank you for joining us this afternoon.
Thank you. It's been a pleasure.
So we're now going to move on to the third project. So this one is about staff wellbeing advice and support service and the Wellbeing Champion Network. And we have Matthew Tidball, who's the physiotherapy lead in Swansea Bay University Health Board. Welcome. And we're going to start off with your video. Thank you very much. It was going so well then. The video started and then it stopped. Here we go. Okay, really great video there. So I'd encourage anybody to put any questions in the question and answer. And I think Matthew, you've been joined by some colleagues as well, so that's fantastic. Welcome. So I'll start off with some questions, if that's okay. I think this is a subject that's close to all of our hearts, really. Everybody probably who's on the call in terms of supporting staff wellbeing through what's always a difficult time in the NHS, but even more so, you know, during COVID. So obviously a really, really valuable service that you've been offering there. And I was wondering what you feel people would have been doing if they hadn't had access to your service, you know, what the alternative was for people. Obviously, you obviously saw that there was a need there. Could you tell us about that?
Yeah, I'll take the lead on the answers today, but I'm joined by my colleagues Beth, Ruth and Rosie as well, so they'll dip in a little bit as well.
Great.
It's probably important to mention our project is actually a bit of a historical project from 2018, 2019, so we were pretty well established by the time COVID hit, really, and we were able to offer a range of support ultimately when the pandemic first hit. In terms of support available, what we actually found was that individuals perhaps weren't accessing support at the time we initially thought they would. And what we actually kind of identified was that people were beginning to access our services that maybe after the first wave and after the second wave. So that was something we found quite interesting, really, in terms of people accessing our support service during that time.
Great, thank you. And I noticed, you know, you talk about presenteeism is in the video, I think, and that's really interesting, isn't it? That people are in work but actually really, really struggling. So was that something that you picked up through the calls with staff?
Yeah, absolutely. I think most of our service users, participants, patients are presentees. They're in work, but maybe they're struggling with their physical or mental, emotional health. The biggest reason for referral to our service is because of mental, emotional health type issues, and this has obviously been exacerbated further by the pandemic, by the service pressures out there on the front line in particular. But like I mentioned, it was quite interesting. We kind of reacted to what we felt would happen in terms of extending our service delivery. But in hindsight, it was perhaps after the waves where people were beginning to address their own health issues, really. They were perhaps in the fight or flight mode, busy on the front line in their day jobs, caring for their families, their other responsibilities, that actually, you know, we were able to evaluate that data, evaluate the numbers referring to our service, who was needing support. And, you know, it was actually clear that perhaps people needed support at different times to what we were actually expecting, which is quite interesting.
Yeah. So have you found that because I'm assuming the service has continued and is continuing. So have you found that you've adapted it in any way? Has it changed recently?
Yeah, so I think when the kind of pandemic initially hit, we had a couple of challenges that we were faced with. So first of all, the expected increased demand, and secondly, accommodating the COVID restrictions. The initial Bevan Exemplar project was set up as a Monday to Friday 9 to 5 service. All our advisors were based in our offices at Neath Port Talbot, and obviously that was needing to change very, very quickly. So we were able to set up a steering group. We were able to introduce extended service delivery between 7 AM to 9 PM, 7 days a week. We actually adopted our service delivery model to a 1+1 model. So that meant that individuals could have an initial appointment followed by one follow-up. This allowed us to support more people in a timely manner. Our OTs, counsellors, psychology colleagues worked together. They were able to provide specialist support for trauma and bereavement. We were able to offer a 12-week mindfulness program accessible via the intranet and social media feeds. You know, this was certainly something we looked to do a lot more of, was use of social media, use of different ways of communicating. We worked with colleagues from the Armed Forces Service Improvement Team to implement TRIM, the trauma risk management. We obviously worked remotely, so, you know, pretty much overnight, all our advisors were working from home. We linked with IT to ensure everyone had the appropriate equipment. I know people have touched on this already today, which has been really, really interesting. But, you know, if anything, the pandemic accelerated some of our changes. You know, during the kind of initial period, we quickly realised we need to switch to a paperless system. we were using paper notes. We discussed for some time the need to switch to a paperless system, which would be more efficient, more prudent, allowed for remote working. But the pandemic certainly accelerated that change, and I think it's an example of a challenge being turned into an opportunity, which again has been discussed in some of the other sessions today. And like I said, interestingly, the trend wasn't actually what we thought would happen. We kind of reacted to thinking, right, everyone's going to need support. Let's extend our service delivery. Let's bring in extra support. Let's bring in extra colleagues. And in reality, most people were still contacting us 9 to 5. And if anything, our referral numbers actually increased after the end of the first wave, and again after the end of the second wave, not during the kind of height when we first anticipated we'd need to kind of jump in and provide this additional support.
Yes, that's interesting, isn't it? Learning in terms of how staff are dealing with that, and when they address their own issues and needs, I guess, isn't it? Yeah, that's a learning I think we've all had from COVID. Yeah, absolutely.
Yeah, I think as a team and a service, we kind of jumped into that fight and flight mode ourselves. We were kind of, right, let's hit the ground running, let's develop our services, let's support staff as much as we can. And like I said, in reality, it was the kind of capacity and demand wasn't matching up. And within a few months we reverted back to our usual 9 to 5 service, which has been able to provide adequate support to staff members throughout the pandemic, we feel.
Okay. And I just wondered, as a team as well, obviously you've evaluated this, as a project, haven't you, in order for you to bring it to us today. And I wonder what have you learned from that in terms of that sort of process of evaluation of something very innovative like this?
Yeah, I think we're quite lucky in some ways, because historically our little project has been Welsh Government funded. Right. So initially we were Welsh Government funded, so we were quite aware of the need of regular evaluation, I guess, and we were, Beth, my colleague who I've worked closely with since 2015, we've been involved in a number of small scale service evaluations, I guess, which we've used to feedback to Welsh Government. So it's something we've done on a regular basis. Our last kind of significant service evaluation used pre-COVID data, but displayed positive work-focused outcomes in terms of helping individuals stay in work or return to work. As the video displayed, we used the EQ5D5L outcome measure. So for those of you who are not aware, that's an individual health outcome measure, and we use this pre and post intervention. And again, for the majority of individuals accessing the service, improvements in health outcomes were demonstrated when we compared the pre and post intervention data. Some interesting themes that came out of the recent evaluation, I guess, were that those accessing for mild to moderate mental health issues actually experienced greater improvements. But I think it's important to mention some confounding variables there, that generally speaking, the health status of these individuals were lower at the point of referral. So there was greater scope for improvement during the intervention period. They also tended to have a longer intervention period, so they received more intervention in theory from our service, but also a longer time for natural recovery, medication, organisation, and all social factors to be addressed as well. It's important to mention we do also collect qualitative data. So we use feedback forms, we encourage feedback. Basically, we want to know what we're doing well, what we can improve on. We discuss these feedbacks regularly during our MDT sessions as well. Prior to today's session, my colleagues have done a quick trawl of some of the more recent data from May to August, just to give you a snapshot really of where we're currently at with things. So we received 220 referrals between May and August. The average number of days from referral to first appointment was 6 days. So our aim is 5 days. So we're slightly off target there, but based on the kind of increased demand and the new ways of working and the other things we're involved in as a service as well, that's expected in some ways. And in terms of individual health outcome measures, so the EQ5D VAS scores or visual analog scores, The average pre-score for the 220 was 64, the average post-score was 76, so we've noticed an average improvement of 12 for those accessing the service between May and August. So again, it appears that the work-focused outcomes and the individual health outcomes are still positive, you know, at this stage.
That's fantastic. And are there any sort of skills that you think you've learned as a team through this process that you would, you know, encourage others to do a similar thing and to benefit from that learning?
Yeah, absolutely. I think, yeah, we've learned a great deal. You know, I came into the service back in 2015 as an MSK outpatient physio, so I was used to the kind of bread and butter physio, I guess, in the department. I know lots of my colleagues come from different backgrounds as well, so being involved in service development, service improvement, evaluation, networking, communication, it's all been new and a learning experience, but something I think we've all kind of risen to the challenge, I guess. And I've just jotted down some bullet points, I guess, of key learning, which I'm keen to share with those in attendance today. And also, you know, I think as a team and as a service, this is what it's all about. It is about sharing what we've done and how we can allow others to adopt this same approach. So, you know, if anyone does want to get in touch with us, we're more than happy to accommodate a Teams meeting, a call, whatever's needed. But just to say, I think firstly, the results have demonstrated that the service can provide timely advice and support to staff members experiencing mild to moderate mental health problems and MSK problems. Secondly, from an organisational perspective, this type of support can help individuals to remain in work or return to work. And thirdly, from an organisational perspective, it can lead to cost savings in terms of reducing sickness absence costs, overtime agency costs. And most importantly, I guess, what we know is that a fit and healthy workforce can actually lead to improved patient care and experience. So, you know, this type of service can work, it can benefit the staff member, importantly, but can also benefit the organisation and our patients that we care for. I think in terms of messages to potential interested parties, the first thing I would say is just fail to prepare, prepare to fail. It's the old saying, and preparation is absolutely key. I think we were lucky as an existing service. We had a similar kind of sister service that was supporting small to medium-sized businesses in the area. But there's a lot to consider prior to launching a service of this nature. The first thing about engagement, you know, talk to your stakeholders, consider the logistics, admin support, assessment documentation, outcome measures, you know, and the need for ongoing evaluation, suitable database, marketing materials, resources. There's so much prep work that goes into something like this. It's not a matter of opening a phone line and manning that, you know, 9 to 5. It's a lot more behind the scenes. In terms of communication, you know, it's clear you can't do this on your own. We can't do this with a small wellbeing team. We need to make staff aware of the available support. We need to spread the message. The intranet, the health board communication team, staff and managers, HR colleagues, union representatives, our directorate colleagues. And I think, you know, closely linked to this this short presentation today, I guess, is the Wellbeing Champion Network, which my colleague Beth has launched and drives in our health board. It's a separate Bevan Exemplar project, but again, as demonstrated outstanding results in our health board, and something we're keen to spread and share with other health boards in Wales and further beyond. So anyone who wants to know more about the Wellbeing Champion Network, please get in touch with Beth. I think it's important to also point out the distinction between OC health and wellbeing support, just dispelling some myths and removing some barriers around that, and creating a culture of wellbeing which is top down. You know, our service alone isn't going to fix the problem. There needs to be time and space for the upstream, the proactive, the preventative work to support our staff to provide the best possible care.
Yeah, absolutely. Thank you. Okay, just before we finish, I can see there is a question that's come in. Somebody's asked about how the findings from working with individuals and teams is fed back through the organisation or the organisational senior leaders for improvement opportunities within their teams, is the question.
Yeah, I may pass this one on to Beth, if that's okay, because I know Beth's involved in collating the information and sharing that with senior team.
Okay, thank you.
Just take my mute off. Yeah, well, we regularly feed up through our manager, who's the head of staff health and wellbeing, then through to workforce and OD committee, and then upwards that way. So feeding back on our activity, number of referrals and outcomes, and you know what we're doing for teams as well, and feedback that we're getting. And our engagement as well with perhaps outside organisations that perhaps come in, like Time to Change Wales, etc. We're trying to capture everything really that we do and feed that up constantly.
Fantastic, thank you very much. Thank you. I think we're almost ready for our next session, so I think I'll bring this one to a close if that's okay. And thank you all very, very much for joining with us. That was really, really interesting and really good to hear how you're supporting staff at this really, really important time. So thank you very much for your time today and sharing your project with us. Thank you. And I shall close there and pass on to the next session. Thank you, everyone.
Hi everyone, and welcome to the final closing session here. Thank you very much for staying with us today, and for those of you who've just joined for the closing session, welcome. What fantastic presentations we've seen and heard today. What fabulous people we've seen and heard from, and what enthusiasm and delightful initiatives we've seen. I think we said at the outset that actually you're going to see a whole range of different projects across a whole range of areas, but it's the people, I think, that actually make this, and it's certainly important that we thank them for not only today, but thank them for putting their, if you like, sticking their heads above the parapet, being brave and bold to say, look, I'm going to have a go at something different, even though it may or may not work. I'm just going to have a go. So thank you, everyone. And thank you for going the extra mile. This has been, for many, if not all people, it's been actually about going over and above the work that you do on a day-to-day basis. We have thoroughly enjoyed working with you, and we will continue to work with you, as well as with our new cohort. So a big thank you to everyone. I do hope that you've been able to not only learn from today's session, but take away something over and above the projects themselves. Take away something that really inspires you to go away from here today and to do something different, to change, to make a difference, to take something that you've heard from today and take it back, share it with others, don't keep it to yourselves, and to do something about it. I'll come back to that in a moment. Firstly, I really want to thank, as I said, the participants for today. I want to thank also the chairs. I'd like to thank Vanessa Hayward, Denise Jenkins, Mark Knight, Angela Bell and Lisa Lovegold. Thank you guys so much for all your support through this. We've really value your support in this. And of course, we will continue to value that support as the committee, as the Allied Health Profession Committee, continues to take forward and look in further detail at the work, the projects, the individuals, to see just how we can take up the offers that we just heard in the last presentation. People are almost really, enthusiastic to share with others what they've learned, and to certainly share some of the barriers and some of the opportunities they saw. So please take up on the offer and have a go and be bold. So we will be looking forward to working with the committee over the coming months to see just what happens to these, because as we said at the outset, doing the work, developing the ideas, trying out and testing these different ways of working is but part of the, if you like, solution as to how we can work towards more sustainable health and care in the future. And as Ruth said earlier, how can we do things differently? How can we, for instance, work in a different way in the community, closer to people's home? Just thinking about that and looking at how we can take some of these ideas forward. The ideas themselves are just part of it. The ability to do something with it, to take somebody, whether it's your idea or somebody else's idea, and spread it and encourage and enthuse other people across Wales. This is the only way that we're going to make things different, that we're going to make things sustainable, and the way that we're going to actually set Wales above the, if you like, the rest of the, not just the UK, the rest of the world, by taking ideas and making them work. There are a number of tools that people can draw on from their experience with the adopt and spread work. And if you go online, you can see much more about that in further detail, to look at particularly issues around boxing up your innovation and so on and so forth. But please go on and have a look, continue to share the ideas, not just the ones you've heard today, the ones that we also have, those people who couldn't make it today. Go and have a look online to see in your area of expertise where you might be able to develop things differently. So a big thank you to everyone, and a big takeaway message, which is don't just go away and resume as normal. Think about how you can do things differently. So I'm going to hand over to Tom now, and he's going to take us through a few aspects that we wanted to make you aware of. Tom.
Thank you, Helen. And yes, just to reiterate some of the points made, a huge thank you from all of us to all the presenters and to all of the attendees. And we just encourage all of you to keep going, keep all the passion and the drive you have and the motivation, and just let's carry us forward and drive it from the ground up. So I now have the pleasure to introduce a number of exciting opportunities to you, which I think many of you may be interested in, and we've got a range of speakers and opportunities to share with you today. This will start with me introducing Professor Chris Hopkins from Hull University Health Board, who will talk about the Tritech Institute and its activity in this space. Chris.
Thank you, Tom. Can you hear me?
Wonderful.
Yes. Thank you ever so much. Yeah, I'm Professor Chris Hopkins. I'm the scientific lead for the new Tritech Institute that we've established within Hull University Health Board, and I'm a clinical scientist by background. I haven't got a set presentation for you all today. I just wanted to take you through really some of the learning we've had during the pandemic period, and what that sort of eventually materialised towards the Tritech Institute. So the last 18 months has been extremely difficult for us all, and particularly challenging for the NHS. But I'm very much an optimist, and I firmly believe that there's always something good that comes from something that's been so so awful really for a number of people across the globe. During the pandemic, we were involved with a number of technology developments. We were involved with ventilator development, with CPAP development, mainly because the global supply chain really struggled with a number of these devices that we needed to. We obviously needed to support our respiratory patients in particular. And we work quite closely with a few manufacturers locally, with the local universities, to develop those devices. And thankfully, the long and short of it was that we didn't need to use them. But at the end of that, as part of the learning, we were encouraged to sort of think about, okay, well, what can we do differently in the future now? And our R&D director, Dr. Leighton Phillips, and myself sort of sat down and just sort of pondered over some of these ideas. And one of the things we felt quite strongly about was the ability to have a dedicated team that could really drive technology, innovation and research moving forward, because more often than not, we do it on top of our day job, which means you can't devote really enough time to that sort of concept and those ideas. We were quite fortunate that we put the business case in, and our executive team were very supportive. Our finance director, of all people, is very much a visionary in this sort of arena, and he's been nothing but supportive all the way through. So he not only supported the team, but he supported new premises and everything else that goes with that. So I can only thank our executive team enormously, really, for sharing that vision with us moving forward. So what's it all about? Well, there are three fundamental aspects to the TriTech Institute. Number one is what we call core research. So any sort of technology sort of research opportunity, if you've got a real need out there, if you've got something that you need to plug a gap with as far as the technology, whether that be what I call a typical medical device or even a software app, for example, if you've got a need, then we can support that development through a research perspective. We also provide what we call real world evaluations. So these are already established devices that we will take through a real clinical sort of scenario evaluation with value-based healthcare and all sorts wrapped around it to actually demonstrate the potential of these technologies and these devices. That's not just from a financial perspective, obviously that's more importantly to us from a patient perspective. Can we actually see any positive impact from any of these technologies? And we're currently working with a number of commercial suppliers around a number of those projects. And we can also help with what we call consultancy advice as well. So I say unfortunately, there is a reason behind the regulatory framework within the UK. Ultimately it's there to support patient safety, but it's a very complex environment to navigate. And we sometimes find that lots of people have very, very innovative ideas, but then are put off by the framework within the UK because they find it very difficult to navigate through that. So we provide an element of consultancy there as well. Just to give you some idea on sort of, it is very much a Hywel Dda development. However, we're very keen to support the whole of Wales with this because it is the first of its kind across Wales. And also what was really important to us was to forge the partnerships with a number of the universities. So when I say partnership, I don't mean that loosely. It's a very strong partnership between Swansea University and the Healthcare Technology Centre, and also University of Wales, Trinity and St David's, and the institution within that university called ATIC, which is the Assistive Technologies Innovation Centre. And we're very keen, we're starting to have conversations with Cardiff University and also Aberystwyth and Bangor as well to try and pull that in to more of an all Wales approach. We've also got very strong partnerships, you can see them on the slide there, with Arch, we've just signed an MOU with the Welsh Wound Innovation Centre, with Bevan Commission, obviously, and a number of the universities are on the slide there as well. Okay, so there are a number of organisations across Wales that bring something different to the concept and the idea, so we're very keen to work quite collaboratively there. Please don't feel that because it's Hywel Dda that you can't come to us with any sort of ideas or request any support. The team was obviously established to support the Hywel Dda geography, but those of you that have the pleasure of social media, you might very well have seen the TriTech Challenge, which we published just recently. We put £80,000 basically into the pot. to support 4 innovative projects that we could take forward. So it was £20,000 per project. We had 28 ideas presented for stage 1. That now has come down to, through the scoring and the panel sort of assessment, that's come down now to 8 ideas, and we'll be assessing those ideas this evening. That's through the stage 3 event this evening at 7 o'clock on Zoom. And then 4 of those projects then will go forward then to basically the winning entry. So we will support the development of those ideas. Just to give you some examples of those projects, there's one around cancer support. So it's an app development for cancer support for patients, so they can share their experiences during that process. There is an artificial intelligence device for patient falls, particularly at home, but I think that can be definitely adapted for hospital environments as well. There's an app to reduce delays in discharge, and there's an app to support long COVID patients as well. So a number of ideas coming through, but I would welcome anybody getting in touch with us, and in any way we will definitely support you. We can also support you through the grant process as well. So if you have an idea but you don't have the funding available, we can help you through the grant process as well. So that's it, and I'm very, very happy to take any questions whatsoever, ladies and gents.
Thanks, Chris. Is there any questions? I can't see any at the moment in the Q&A panel. But if any do pop up, we'll also pass them on to you, Chris, if that's okay. I'd fundamentally encourage working closely with Accelerator, fundamentally encourage people to get in touch with the TriTech Institute and have a discussion about just if they've got broad ideas, refined ideas or whatever, have a discussion with them and see whether they can support it. It's a fantastic opportunity and one that could be sorely missed. So our next opportunity, so I'll be passing back over to Helen Houston to talk about the Intensive Learning Week.
Intensive Learning Week. Many people are unable to become exemplars for a whole variety of reasons, and many people are also unable to join standard, if you like, academic type studies in the way that they are organised, whether that be 2 days a week or 3 days or whatever. So we, as part of the Intensive Learning Academy, decided that what would be really helpful, we thought, having talked to people, was try to condense the information and the work that we do with our exemplars over a year into a week. Now, you know, that sounds virtually impossible, and I'm sure it will be virtually impossible. But what we're going to try to do is to bring a whole range of our information, our support, our insights, our studies, our challenges into that week. We will be bringing lots of people in. There will be an intensive week where you can, or anybody who wishes to apply to attend, and I think it's free for participants from Wales, can just apply to come for the week. And we try to take you through that journey in that intensive week. We expose you to our commissioners. We will be exposing you also. We have an international webinar the same week. We will have, and you will also be, if you like, challenged to bring to the front some kind of, if you like, challenge that you would like to resolve. So we ask you to bring it, and we will talk to you about it at the beginning of the week. And the whole idea is that we bring around you, we bring to you a whole range of support that will help and enable you to see that project, that challenge in a different way, so that by the end of the week you have something to take back to your organisation. You have a solution, you have had the opportunity to think about it differently. You have had the opportunity to meet with a whole range of people who also are interested in finding out more about innovation, more about transformation, and the skills and the competencies that they need, that you need to actually take it forward. We'll be looking at behaviour change, we'll be looking at innovation itself in further detail, we'll be looking and giving you the skills and competencies to help you go away and actually take this forward yourself. So if you've not signed up already, sign up now. The Intensive Learning Week, it is open, the information is available, and again, we only have a limited number. So if you're interested in that intensive week where you can access the kind of support that our exemplars have had over the year, sign up now. Thank you.
Thank you, Helen. Next, I'd like to introduce Dr. Gary Warpole from the Circular Economy Innovation Communities Programme. Thank you, Gary.
Just take myself off mute. Good afternoon all, and thanks for the opportunity for speaking this afternoon. I'm going to talk briefly through this one slide that introduces the Cake Wales programme, obviously based from the acronym Circular Economy Innovation Community. And if you're looking to follow us on Twitter, the guys have developed the Twitter handle of Welsh Cake. So we're an ESF funded programme, as you see on the bottom there, operating in the Swansea Bay region and the Cardiff Capital region. And the two logos you can see on the bottom there being delivered by Swansea in SBR and Cardiff Met in the Cardiff Capital region. We're delivering a 10-month innovation programme designed for, let's say, operational managers and leaders, not traditional innovation specialists, to introduce them to innovation tools and techniques and encourage them to develop a much greater knowledge of circular economy principles in order to apply those to potential new services and potential products that they might develop and deliver, and also apply CE principles to their existing processes and practices. We'll do that through a 10-month formal programme. As you can see, we create a community of practice from those that take part in the cohort. We're running 7 cohorts between about now. We've actually started 2 in Swansea, so we've got 5 left to deliver till the end of 23. And we'd like to bring in between 20 and 30 practitioners to come together, form a community of practice, and we'll support that formation and give them the tools and techniques in order to sustain that community of practice beyond the 10 months of the programme. In terms of the content of the programme, as you can see running through the middle there, we have a 2-day experiential residential event where we introduce people to innovation dynamics, all through experiential learning exercises and activities, which both introduces them to fundamentals of innovation and also develops their ability to act as critical friends and forms that community of practice. We then, through monthly workshops, take them through the design thinking phases, the 5 bubbles you can see in the middle there. So they'll go through an empathy phase with the challenge or problem they're looking at. They'll then define what that challenge problem looks like from both users and stakeholder perspectives, then start developing solutions through that ideation phase. We'll then support them to prototype and then test and learn the solution that's developed. We will hold 2 conferences next year and the year after, so that Swansea and Cardiff Capital regions can learn from each other, but we'll also invite, and Helen's been very supportive in this respect, invite colleagues from both across the NHS, but across public services, to share that knowledge within those conferences that we'll hold biannually. So I think that's probably done my 2 minutes. And so any questions would be more than welcome.
Great, thanks, Gary. And I know, looking at the new cohort for the exemplars, we have a number of green and circular economy related projects. So it'd be interesting to see how these linked in as well. Next, I'd like to introduce Louise Carrington, who will be talking about the Cancer Innovation and Improvement Programme, and we'll start with a little video to introduce us to this. Thank you.
Hi, I think that's the Thank you very much, and apologise if this is a little interrupted, as I'm juggling children coming in and out at the moment, as well as this. Joys of working at home. So I'm going to keep this very short because I'm aware that you've had a really long day with a lot of ideas and plenty of things to think about. But we're from the Wales Cancer Network, we're really pleased to be working with Bevan to open a programme of support and funding for people who have ideas to tackle the pressure and problems at the beginning of the cancer pathway for patients. So that's anything from symptom awareness and screening through the process of diagnosis. We've run funds before, but we're aware of, having looked at where there are problems, that the people on the front line, yourselves, have lots of ideas. You know where the problems are, and you know probably what the solutions are, but sometimes those things you don't have the time, the space, the support and the agreement to go forward and explore those, and we want to be able to wrap a programme around successful applicants of bespoke support from Bevan and other innovation leaders, as well as some funding and agreement from your employers to take something forward. So we're open to applications now. We're particularly keen that non-medical clinicians and people not from that obviously treatment end of secondary care apply. If you have any ideas and you're not at all sure whether it's something that we would be interested in, please get in touch because we can help with bid development as well. So that's it. Thank you very much for letting me introduce this. Anybody who has even a snifter of an idea, just get in touch and we'd be really happy to explore. Thank you very much.
Great, thanks Louise. And yeah, just to signpost even further, if anyone does has an idea, as Louise said, please do get in touch, and I'm sure Louise and Rupert will be able to give you more information and guide you through the process of applying. I think we will now play a short video about the planned summit. I will then hand over to Ruth Crowder to close the day. Thank you.
So this event is all around how we shape and reform plant care services in Wales. It's around promoting how the new plant care approach is going to be delivered and embedded within NHS organisations. It includes NHS recovery, the wider system reform, and promoting some of the enabling working agencies that we've got working within NHS organisations to achieve better ways of greater integration across the care pathway.
Lovely. Diolch yn fawr. Well, thank you. We're very close to the end now, and I will just end with a few reflections. I think my starting word is wow. What a day. The range and creativity of the work that you're doing, the range of partnerships that you're working in has been so impressive. I think one of the key things that came over to me was the passion and the way in which people were so eager to share their learning, share their ideas, and to really embed that in terms of the outcomes that you have been achieving and are starting to achieve, and your intent to drive this forward. So I will echo everybody's thanks. It's really impressed me today, and I've been here all day. What I think is really striking is I don't think many people really know what we all do. And actually, the range of places that you described that you were working, the range of impacts that you are having, the range of people in our most vulnerable communities that you are making a difference to, even surprised me. So I think there's a really big piece of work to do about making sure that we help our colleagues understand the range of what we offer and where we can make a really big impact. You've used service user skills to build quality. You've shared all the way across Wales. I heard people talk about reducing variation. I heard people talking about very rarely discussed topics and areas in healthcare. I heard about modern links that are way outside the traditional boundaries and working relationships that people think we work in. I heard about creative training to enable others to deliver our interventions, about the ways in which you've used tech, virtual, produced resources for other people and for people to help themselves. You've talked about quality improvement and about the research underpinning our clinical and professional skills. And over and above all that, we had representation about work from all ages, all parts of health and social care, through public health, preventative, early intervention, primary and community, as well as that secondary, urgent and acute and ongoing long-term care and end-of-life care. And I talked this morning about the quadruple aim and how those 4 areas underpin the AHP framework, as well as a healthier Wales and all that we're trying to achieve. And I actually heard throughout the day areas and presentations that talked about how we improve population outcomes, about how we enhance the quality and access to allied health professionals, about how you are inspiring and supporting our vibrant workforce. And most importantly, I heard very clearly the message about how you're demonstrating the highest value that AHPs can deliver through transformation. So I felt we're really stepping outside of the box. The confidence and challenge of your current practice is awe-inspiring, frankly. I sat here in silence, just listening, really impressed. The calls and opportunities in this particular closing session really show how much more there is here for you to do and the opportunities that you have to make a difference. So do please contact people who've offered you opportunities here in this last closing session. As I end now, I just want to add my thanks to the Bevan Commission, to the Executive Committee of the Chair of the AHP Committee, to all of the chairs and presenters, to everybody who supported the alumni of the various cohorts, all of those colleagues who've carried things so that people were able to find the time to do this. And thank you to those of you who are putting yourselves forward for the next cohort, because this is really important that we continue it. So thank you, Helen. Thank you, Tom. Thank you, Rupert, Fern, everybody, Lisa, Vanessa. The work has been phenomenal. I'm going to end now and thank you again. We want you to go away inspired and excited to continue. We will finish with a very short closing video. At the end of that, do please go and enjoy the rest of your evening. Diolch yn fawr iawn. Hwyl nawr.